Good morning, everyone. At the outset, I would like to thank Dr. Chandra to give me an opportunity to talk on this important topic. So, I will be dealing with universal work precautions and post-exposure prophylaxis. So, as per statistics which came out in 2019, there are about 23 lakh people living with HIV in adults, and about 69,000 infections are there annually. So, as discussed by Dr. Priyanka, that the end game 2050 is our target, and we're trying to keep a check on the numbers. So, for that, we need primary prevention, which comes in form of universal work precautions, and then secondary, which is post-exposure prophylaxis. So, I'll be discussing universal work precautions. So, universal work precautions, basically, what do we mean by that? Professionals which are at high risk of exposure to potential bloodborne infections, which include nursing staff, students, emergency care providers, in labor room and delivery room personnel, surgeons, OT staff, lab technicians, physicians, interns and medical students, dentists, health facility cleaning staff, mortuary staff, clinical waste handlers. These are the guidelines or the standard precautions which they should be taking care while dealing with anything which is blood products or body fluids. They should assume every patient is infected and they should take care of themselves. Now, when we talk about standard precautions, we are talking about hand hygiene, we are talking about safe handling of body fluids and blood products. We're discussing about proper disposal of sharps and needles. And then we're talking about PP. PP, people started realizing after COVID, but it is very important for us to know, and proper waste uh, elimination. So, waste management. Now, what we tend to do in our day-to-day practice, especially long duty hours, improper sleeps, and medical students, interns, they tend to be a little casual and they start recapping needles, which can cause a needle stick injury. While transferring body fluid containers, they are careless, handling and passing needles of sharps after use, failing to dispose the used needles properly in a puncture-resistant sharp container, and poor healthcare waste management. These are the practices which predispose them to occupational exposures. So one should be very careful handling these. Safe workplace precautions. You should avoid using injections when it's not needed. When you can do with oral drugs, you should prefer that. Avoid recapping. These are the two pictures a lot of us tend to do, sometimes spinal level. The needle disposal, we should either do with these containers you can see, use a needle cutter or a destroyer, use forceps instead of fingers for guiding sutures, use vacuuminators whenever possible, use protective barriers when indicated to prevent direct contact with blood, body fluids such as gloves, masks, aprons, and boots. Now, especially discussing with my gynae colleagues, you guys are dealing with vaginal deliveries day in, day out. When you're dealing with placenta and a newborn baby who's soaked in amniotic fluid, please be very careful, use your PP, because amniotic fluid is very rich in HIV virus and hepatitis B virus. Now, from universal precautions, the prevention and treatment strategy. Prevention is pre-exposure prophylaxis, which I'll not touch on in this talk. And a post-exposure prophylaxis, person when comes in contact, immediate exposure to virus, so that you can halt the seroconversion. And this is a very important time for a person who's come in contact to progress to a disease in due course of time. So treatment is fast and preferably less than 36 hours, maximum up to 72 hours. This is HIV continuum of care. Next slide. Now, I will be discussing about post-exposure prophylaxis. Now, what is exposure? We need to understand what do we mean by exposure. Now, I am primarily focusing on occupational exposure, not the non-occupational. So when we talk about exposure, it's a percutaneous injury, that is a needle stick injury or a cut with sharp instrument, or you come in contact with the mucous membrane of eye or mouth. The contact can be with the non-intact skin, as in case of dermatitis or a chapped skin. And what is important is the duration of contact, if it is prolonged with the blood or potentially infectious body fluid. Now, this is a very important slide. It's a WHO data. It gives us an insight which product is how infected. Blood transfusion, the chances are more than 98%. Perinatal is 20 to 40%. Sexual intercourse is anything between 0.1 to 10%, and there's a higher risk in anal intercourse, which is 0.06 to 0.5%. Vaginal is 0.05 to 1%. Oral is much lesser. Injectable drug use is 0.67. Needle stick is 0.3. And mucous membrane splash to eye and oronasal is much lesser, 0.09%. And if you compare it with hepatitis B, which is far, far more, it is 9 to 30%, and HCV is also more, it is 1 to 1.8%. So when a person is exposed, how do you handle it? So management of exposure sites, the first aid is, there are certain do's. When it's a skin exposure, immediately wash it with water and soap liberally. When there's a splash of blood or body fluids, wash the area immediately. Unbroken skin, again, wash it properly. Eye, you can wash with water or normal saline. Mouth, you need to spit out immediately, rinse the mouth with water or saline. You need not use antiseptics. Now, then you have to establish that this exposure qualifies PP or not. A rapid and a breakthrough risk assessment of hepatitis, HIV and HBV transmission has to be done. And the two main factors while we are deciding is the type of exposure and HIV status. Now, when we are assessing the severity of exposure and the risk of transmission, I will be discussing in the next slide, and then you assess the HIV status of the source. So first dose of PEP has to be given within 2 hours preferably, especially if it's an occupational exposure. Awaiting the report of source, you need not delay. If the risk is insignificant, you can always discontinue if it's already commenced. Now, when you're analyzing the severity of exposure and risk of transmission, they are further, it's a mild exposure, moderate, and severe. Severe is what we need to understand. It's a percutaneous exposure with a large volume in an accident with a hollow bore. It's a high caliber needle visibly contaminated with blood. Or it's a deep wound, which is hemorrhagic wound and very painful. And there's a transmission of significant volume of blood, or it's an accident with the material which has been previously used IV or intraarterial. A moderate exposure is of mucous membrane, but it's a large volume, or it's percutaneous superficial exposure with solid needle. Mild exposure is mucous membrane or non-intact skin with small volumes, it can be eye or a mucous membrane, and subacute injury with small bore needle. And which body fluids you should be very careful of, especially if you're dealing with blood, semen, vaginal secretion, CSF, synovial fluid, pleural fluid, peritoneal fluid, pericardial fluid, and amniotic fluid, and any other fluid which you think is contaminated with blood. And the fluids which you normally don't consider as risk, they are tears, sweat, urine, feces, saliva, sputum, and vomitus. And then you assess the HIV status of the source of exposure. Try to do a baseline HIV test before starting PEP. Initiate if you think it's needed. And then if the source is HIV negative, need not worry, but you have to keep in mind the other two, HPSAG and HCV. If it's a low risk, that is maybe HIV positive but clinically asymptomatic, and a high risk patient, HIV positive and clinically symptomatic. So then you counsel the patient for PEP. When you think patient needs exposed person qualifies PEP, you should tell them that PEP is drug regime which is to take care of the seroconversion and minimize the risk. You have to tell them the side effects and the benefit, risk and benefit ratio. And also counsel them about the details of window period, baseline testing, and drug efficacy. And if the patient is pregnant and breastfeeding, you have to properly counsel, and the drug selection has to be very careful. Then next 3 months, if somebody is on PEP and till 3 months it's not clear, they have to go for safe sexual practice. You have to give them enough psychological support and document everything. Now, qualifying PEP is a percutaneous exposure to blood and potentially infectious fluid, and mucous membrane, including sexual exposure, mucocutaneous splash, open wound contact with blood or potentially infectious fluid, you have to give PEP. If it's mild exposure, you need not. If it's intact skin, need not. So again, I have discussed this slide. You initiate PEP, don't wait for the source report to come. And I've also discussed this, that it should be preferably given in 2 hours. There's a very little benefit after 72 hours, and in animals it has been studied. The best benefit comes up to 36 hours. After between 48 to 72 hours, it may be initiated, but beyond 72 hours, it's of no help. And prophylaxis needs to be continued for 4 weeks. So this I've already discussed. Now these are the NACO regimes. If adult or adolescent is more than 10 years and more than 30 kg, the backbone are these two drugs, tenofovir, lamivudine. You can club it with integrase inhibitor. Dolutegravir is what we prefer because of very good tolerance and less side effects. Alternative regimes, tenofovir, lamivudine can be clubbed with protease inhibitors, which could be lopinavir, ritonavir, or tenofovir, lamivudine could be clubbed with efavirenz. In children more than 6 years, zidovudine and lamivudine is the backbone, and you can club it with dolutegravir. And if the HB is low, then abacavir, lamivudine can be replaced. If it's less than 6 years, zidovudine, lamivudine with lopinavir, ritonavir can be preferred. Now, this is a WHO guideline. Again, it's on similar thought process that PEP regime, 2 drugs is effective, but you should prefer 3 drugs. And again, the backbone is tenofovir with either lamivudine or emtricitabine. It's recommended as a preferred backbone, and it has to be combined with dolutegravir, where there's enough evidence. But other drugs which can be used are again boosted PI, atazanavir, darunavir, lopinavir, or raltegravir. They can be considered as additional third drug options. Now, when you follow up a patient, you have to monitor for acute seroconversion, which within 3 to 6 weeks of exposure, you can come to know, and then refer them to ART center. You have to avoid blood donation, breastfeeding, pregnancy. Patient should be given special guidelines about sexual relationship. They should abstain preferably, otherwise condom protection. And adherence is most important step we need to hammer again. Adverse reaction of drugs may be there, but they have to be counseled and guided, and they appropriately handled. Now, lab follow-up time is for between 2 to 4 weeks. You do the complete blood counts to the sugars and creatinine. At 6 weeks, to HIV antibodies. 3 months, again antibodies, and 6 months HIV antibodies. So this is the PEP care pathway. Assess the exposure and see if they qualify for PEP, HIV testing of the exposed source, provision for first aid if necessary, then counsel and support. You can tell them the risk of HIV infection, give them the benefits and risk of PEP, side effects, adherence, and then give them special guidelines about abstinence and all, allay their anxiety, specific support if there's a sexual assault. And then after initiating PEP, 1 month PEP is advised, drug information is given, and you keep in mind other comorbidities and drug-drug interactions. And if there are any side effects, handle them. You can keep you need to keep a follow-up after 3 months of exposure. And if someone turns positive, you should link them for HIV treatment. And these may be the minor side effects. This is the last slide. These are minor side effects which we need to handle them as and when if they come. So prevention is better than cure. This is what we target. And just in case someone's exposed, post-exposure prophylaxis is what we recommend. Thank you, ma'am.
If there is any question very quickly, she will answer on PEP.
In all our anti-infections, we are getting the HIV, hepatitis B, and hepatitis C test done, right? It is negative. But in 9 months, whether any seroconversion has taken place or not, we don't know. At the time of delivery, sometimes we are blessed with amniotic fluid and giving some variant also this sort of blood. In these cases, suppose we take our cases, should we get the test done? Many times we get it.
That's what I was discussing, that during delivery is the maximum chance for exposure for any gynecologist and people who are taking delivery. Again, source assessment has to be done. And if you think there is a contributory history that she would have a partner who has high-risk behavior and you're awaiting the source confirmation, there is no harm taking the first dose. You will have a source confirmation. You can always stop.
I think 20% of patients need to take.
Yes.
And secondly, that the HIV status of the patient, the HIV status of the patient.
So that it's safe.
Whenever there is a doubt, ideally you see that this was negative, so there is no need.
No, but you take the first, she said we don't know. So ideally it should be done in every trimester. Every semester we have to repeat that cycle. Absolutely, she said it very correctly that if you are in doubt, then have your first dose of PEP or 2 days PEP. Invariably, it is 2-3 days of PEP before the results come of ELISA, and then you stop it if your source is safe. It's not HIV positive. Thank you. Thank you so much. Thank you. Is there any question from Amrita? Otherwise, I just would like to share what ma'am was saying. Like we always would like to also get of the patient as well and the person who is being exposed. Absolutely. I think if there are no questions, there's no question on Amrita, I'd like to close this session and thank you very much, Dr. Chandra, for inviting us and having this lovely session on elimination of other child transmission of HIV. Thank you very much. Thank you both the speakers. You did such a wonderful job.
Thank you, Dr. Richa Devan ma'am and Dr. Harsha Gula ma'am. Next slide. Now moving on to our second part of the first session, that is an interesting panel discussion on prevention of mother to child transmission, case-based discussion. For the panel discussion, I would like to invite our expert, Dr. Gangadhar Sahu. Sir is retired professor and head of Department of Obstetric and Gynecology, BSS Medical College, Burla, Sambalpur, Orissa. Sir has also been ex-dean, IMS, and some hospital, Bhubaneswar. Sir was ex-pro vice chancellor, SO University, Bhubaneswar. Welcome you, sir. Now I would like to invite the moderator, Dr. Mrinalini Meni ma'am, for the panel discussion. Ma'am is head of Department of Obs and Gynae, Guru Gobind Singh Government Hospital, GNCT of Delhi. She is founder, president, Delhi Gynecologist Forum, Southwest. Ma'am is also AOGD subcommittee chairperson, breast and cervical cancer awareness, screening and prevention. Now I would invite our next moderator, Dr. Chandra Mansukhani ma'am. Ma'am is senior consultant at Sir Gangaram Hospital, Delhi. Ma'am has specialty in gynae endoscopy and robotic surgery and adolescent health. And also she is in charge of adolescent clinic at Sir Gangaram Hospital. Welcome you, ma'am.
Good morning, everyone, and we would like to start our panel without wasting much time. I would like to invite Dr. Garima Kapoor. She is a professor at Vardhman Mahavir Medical College, Safdarjung Hospital, and has many publications. And she's also executive member of IFS 2022-24. Next, I would like to invite Dr. Himshweta Srivastava. She's a professor OBGYN at UCMS GTB Hospital, and she's also the past clinical secretary of NARCHI. And her areas of interest are high-risk pregnancy, reproductive endocrinology. Next, I would like to invite Dr. Professor Mamta Dagar. Yeah, so Dr. Dagar is a senior consultant at Sir Gangaram Hospital, and her areas of interest are preventive oncology, gynae endoscopy, and robotic surgery, and also high-risk pregnancy. Then my next panelist is Dr. Tripti Shah. Dr. Tripti is Associate Director in the Department of OBGYN, BLK Max Hospital. And she has authored several books, and her main interests are in high-risk pregnancy and critical care, also reproductive endocrinology. And then we have a special invitee as a panelist, Dr. Morvi Chum. He's a medical manager in an organization named Sathi, which is working towards HIV/AIDS and technical partner with Government of India and a lot of state governments. And also for they are helping in prison in intervention programs and blending clinical training since 1 to 5 years. Yeah, so after the talks on elimination of MTCT and what to do in case of needle-stick injury, PEP, so we move on to the case-based scenarios on how to prevent MTCT or PTCT, and we'll be discussing two different scenarios and what can be done when a lady comes to us. Just a second. Full slide screen. So. Next. we all know that HIV was in fact 2 decades back a huge problem for our country, and we are the one of the nations which we are with our active interventions by NACO and all the partners, the public and private partners taken into account, we have been able to control. It's no longer an epidemic per se, and it's a routine like any other routine thing. Now we are not scared of HIV like we used to be. COVID has come now, so we are more scared of COVID. I think that is also on the wane. As we all know, prevalence in our country is only 0.34%, and but that 0.34% translates into a huge number, as we can see. We're the third largest number of country having people living with HIV/AIDS. And unfortunately, women account for 40% of these all total infections. And the worst scenario is 21,000 children are infected every year. So this is a job that no neonate born should be positive. And so we will be discussing how to intervene. And less than 70,000 children are less than 15 years of age of the infected. So basically, there are main 4 pillars of PMTCT. Like anywhere else, the first is the primary prevention, followed by contraception. If a lady is HIV positive, don't let her get pregnant, right? And then third is, if she gets pregnant, then test her, intervene, have some interventional measures. And afterwards, our job doesn't finish when she delivers. We have to keep the family safe and follow up the neonate. Neonatal we will not be discussing because there's a separate session on neonatal prevention. So this is basically the 4-pronged strategy which we have, and it's all about integration and linkages. And it's not just one person's job, the OBGYN seeing the patient. It's an integration between the PPT3 unit and all the medical physicians as well. And to achieve elimination, like we had discussed earlier, I will not go into details. So the main thing is locate, test, link, treat, and then retain. If a person is negative, we have to help her to stay negative. If she is positive, then we have to help her to continue ART, which fortunately now in India it is free of cost, and this HIV positive lady has an opportunity to get her ART throughout her life. So that is one bonus point which she has. And as we know, we'll be discussing subsequently, without interventions, what are the transmissions, and whether she's breastfeeding or she's not breastfeeding, she's on an ART, we'll be discussing subsequently. And what are the high-risk factors? Obviously, in a pregnancy, if it's a new converted case, a high viral load is very high, or she's malnourished, or she has concurrent STIs, then the lady would be more prone to having high viral load and transmission as well. Also in labor, there are certain factors like prolonged rupture of membranes or the preterm delivery, and then breastfeeding. But breastfeeding, we have seen that in our country scenario, breastfeeding remains the option. So case 1, I would invite my co-moderator, Dr. Chandra, to carry forward from here.
Thank you, Dr. Mani. Thank you. So you welcome all panelists here, and you are full of knowledge and this thing to discuss all the cases. So we are going to discuss the case 1. She's Mrs. X, 26-year-old primary, presented with 2 months amenorrhea. With she has done UPT, that was positive, and she has come for the routine checkup. On routine investigations, because all the battery of investigations were given to her, she brought all the reports, and now her HIV is positive report. So now, Dr. Himshweta, this question is for you. How would you like to proceed for this case? She has come with you and report is positive.
At the start, I'd like to take this opportunity to thank Dr. Chandra and the PAN moderator ma'am and ISOPAR for inviting me here and giving me this opportunity. Thanks to you. And now I'll take up the case. How to proceed with the case? Okay, we have this new patient who has come to us with HIV positive. So first we have to disclose the report to her and maintaining the confidentiality. We cannot be discussing this report in front of any other patient or any other person. At the same time, then we have to provide her the HIV information about this disease and the risk that now the child will have because of transmitting, the mother will transmit this risk to the child. And then we counsel the patient. Problems with her.
Please don't see, yeah, carry on.
And then after giving her all this information, we'll ask to let us make her choice regarding continuing of the pregnancy, because as Pam has also said, we have to ask them to have a family planning services also. So if she wants to continue or she wants to terminate this pregnancy. And at the same time, then we have to involve in this program. It is not an ANC-centric program. It has to be a family-centric program. That means we have to involve the spouse and other family members, other siblings, or other. In this case, it is a primary traveler, we all know. And then we have to link this patient to any ART center so that she gets her ART treatment started, and also to encourage her to understand that she has to continue this ART treatment lifelong for her health also.
So it is very important to, first of all, you have to disclose the report, and you have to ask her whether she wants to share this information with her husband, family member or not. That is very important. Yeah, so another question, because what should be the counseling? So what important points you would like to cover in the counseling, this patient?
Yeah, in this, we have to, first of all, we have to counsel her for her nutritional counseling, for having a positive living, for safe delivery, and having an institutional delivery, and starting the ART treatment. Then we have to also counsel her with her partner that she has to have a safe sex with her partner, and nutritional counseling along with the other ANC treatment like iron, folic acid. She has to have a good nutritional support in her family and for her own health. Then we have to counsel her that after institutional delivery, she has to be encouraged to come to an institution for delivery, because we can initiate the PPTCT programs. And for her infant also, she might have to take the infant ARV prophylaxis.
Yeah. So in the important points in the counseling, first the disclosure, first whether she wants family members to know or not, and plus if she wants to continue, because she has to decide whether she wants to continue this pregnancy or she wants to terminate this pregnancy. We have to explain her, or if she wants a spouse with her, then we can call the spouse and discuss the options of continuation and discontinuation. Then if she wants MTP, we have to counsel her accordingly. If she wants to continue pregnancy, then we has to take the ART, and what are the chances to the baby and how to reduce that chances. So these are the most important things. And plus, if she wants to continue and she wants to be on the ART, the adherence to the ART, that is the most important thing.
Yes, that's the most.
Have to hammer again and again. Yeah. So another question: if she doesn't want to continue pregnancy because she's worried about her baby, so she wants to discontinue, or she is thinking. So what is the role of the MTP?
Yeah, here we like to say that for MTP, WHO has not given any special consideration for to use or not to use. So here we can offer her both surgical as well as medical abortion, which both are safe for the HIV positive patients.
Yeah, so WHO recommendation is same, you correctly said. There is no different thing in the non-HIV and HIV patient, but we have to counsel in detail that if you want to terminate, then you can. And these are the two options, surgical or medically. Okay, but we have to be very, very respectful with these patients and non-judgmental. That is the most important thing. Yeah, so we have covered this first case, how to disclose and what the important points in the counseling and what the role of the MTP in this case. But HIV positive is not an indication for MTP. We have to counsel her again and again. She can produce a baby without the infection or with only risk of the 1 to 2%. If you give the ART and she's adherent and very diligently she takes the ART, then she can reduce the chances of infection to her baby to less than 1% or 1%, just 1%.
Just 1%.
Even she can feed her baby with the ART and ARV to her baby. So the chances are only 1 to 2%. We have to explain her in detail. That is the most important thing. Yeah, now I invite Dr. Mani for the
One thing I would like to add here is, like we mentioned, disclosure, whether she wants to tell her husband or not, right? Suppose she decides not to tell her husband. So what about the husband's rights, right? So legally, suppose we have to then counsel her again and again. Suppose twice I have counseled and she's a husband ko nahi batana, but he's a sexual partner. So under law, legally, if we now tell her, okay, fine, you're not disclosing, but we have to tell him because we need to test the husband as well. Suppose he is negative, it's a discordant couple. So that then it becomes very important. But invariably in our country, we see it's not a discordant couples are very rare, right? So that point is very important. Now moving on to the next case. My family, no need. That's a couple's decision. Family. If the lady desires, then we can do a family counseling. If she desires, if the couple desires.
Then only
Yes.
family can look after her in a
Yeah,
proper
in
way.
the
So that is, if she wants,
Yeah.
family should know,
Yeah.
then only we can disclose to the family, otherwise. no.
Because what happens is, suppose this lady of her exclusive, she doesn't want exclusive breastfeeding and she's opted for top feed. And now the family is there after a delivery. They will say breastfeed kyun nahi kara rahi hai? So then there becomes a problem. So what happens is, we had one or two patients who ended up giving mixed feed, which is so dangerous as we all know. So that's why if the lady desires, the couple desires, then only we involve the family. Now moving on to the next case. Now this scenario is we have a 30-year-old, a second gravida, a known case of HIV. Now she came to us at 24 weeks of pregnancy and she was diagnosed with HIV during the last pregnancy 5 years back. And she was a very compliant patient, received her ART during the pregnancy, but later on afterwards she stopped on her own. The compliance was gone. Maybe we did not counsel her enough. So now presently she is not on ART. So the scenario is the CD4 count is 270, viral load is very high. So this is the scenario. Now we would like to know from Dr. Mamta Dagar, what would we do further in this case? Would you like to start ART or which regimen would you prefer?
Definitely, and this is not a very uncommon situation. We have encountered these women who were taking care in the previous pregnancy, and they probably became non-compliant, or probably there was something that their therapy is over, and they are pregnant, but they thought maybe the previous treatment is given cover. We do not know the caliber of the lady, but definitely we have to do justice to this woman as per the DATU guidelines, irrespective of the viral load. This woman needs the treatment.
Precisely.
And the first time treatment for this is the TAT combination, which is a fixed dose combination of tenofovir 300 mg, lanifibranor 300 mg, and dolutegravir, which is a very important component. 50 milligram. This fixed dose combination, one tablet taken any time as per the wishes of the lady, the time which is convenient to her, and but at the same time we need to counsel her the risks. Now she has crossed 24 weeks, so there is no risk of dolutegravir. But actually in the first trimester, we have to counsel this lady about the potential risk of neurologic effects which are associated. And in that situation, the periconception period, or in the first trimester, you have to replace this with epiviral, which is not associated with this. Dolutegravir is a very good drug, suppresses viral load to wider extent, and is more tolerable, is more efficacious, and decrease side effects.
So could you, for the benefit of audience, revise the NACO guidelines? What are the NACO recommendations?
As
Here?
very briefly highlighted in this table, the ART regime is a combination of tenofovir, lanifibranor, and dolutegravir, which is a single pill, one tablet at bedtime or 2 hours after dinner. In the women who are the HIV-1, HIV-2, HIV-1 and 2 infected, or the women who have been exposed to single dose of amlodipine in the past, or co-infected with TB or hepatitis. So the regime is clearly, and the pregnant woman with HIV should be educated about the benefits and risks of dolutegravir to help her inform choice, as I explained earlier. may have different situations, not always, because whenever the woman is started on ART pregnancy, always the drug resistance is a certain person. And after that, the ART is started, all you know that she may be resistant to the kind of ART which you are thinking as a first line. You are on the field with.
Yeah, thank you, Dr. Mamta, for elaborating that. And we are like in this lady, she was HIV positive 5 years back. 5 years back, we did not have TLD. Our regimen was nevirapine based. So that's why we have to be more important for counseling and selecting our regimen, what we want to give her. So initiating this, like you have already mentioned, the advantages are it is very good in viral suppression, and also fewer sexual transmissions are there while using the DTG, and it is more cost effective, and also MTCT is also reduced, and adult mobility resulting from associated weight is also not much, because sometimes there is a slight increase in the weight gain in a lady. And now, what are the chances of MTCT in this present scenario? Had she not received, because she had not received ART in the first trimester, and the viral load is also high, and she's 24 weeks.
Yeah, so sort of you have to, like, she's HIV positive without any treatment. And here the risk of transmission is 45% if there is no intervention and no antiretroviral drug or no ART. However, this risk is minimized to just 1% when she has completely taken the triple dose regime of ART and she's not breastfeeding. But if she has taken the complete dose of ART, she has been on 3 dose regime, but she's breastfeeding, this risk is not significantly higher because ART has covered the transmission risk, and the risk, even if she started breastfeeding, is 2%. However, we need to understand that without anything, it is up to that 45%. And the risk is advances as the pregnancy advances. During labor and during pregnancy, it is up to 10%, and during labor and delivery, it increases from 10 to 15%, and during breastfeeding, further increases from 5 to 10%.
Yeah. So basically, for ideally to have these decreased transmission, it is recommended by NACO and WHO as well that a lady should be given at least 24 weeks of ART during antenatally, so as to reduce PMTCT. And with all the interventions, we would definitely will be reducing the transmission rate. So our basic aim is to reduce the transmission and also keep the lady safe. So for moving on to the next scenario, I would like to invite Dr. Chandra to continue.
So that is the most important transmission. Just I want to add one point. Yeah. So transmission is during pregnancy 10%. So still there is a time. So when she has come at the 24 weeks, still there is a time. So we have to start ART immediately. And again, we have to counsel. You are not taken now. Please adhere to the ART and reduce the chances of infection to the baby. That is more important. So now we are moving to the another case. This patient, Mrs. C, 28-year-old, primary gravida, 38 plus 4 weeks pregnancy, presented in the gynae emergency with frank leaking since 1 hour with mild pain abdomen also. She was diagnosed as HIV positive and was put on ART before pregnancy. So before pregnancy, she was already diagnosed and on ART. Patient was very compliant, had regular ANC checkups and took ART throughout the pregnancy. 1 week back only, her CD4 count was more than 500 and viral load was less than 1,000 copies. Now, this question, Dr. Garima, is for you. How will you proceed in this case for the mode of the delivery, especially?
Thank you. So this is a case of a lady who's already actively supervised coverage, and she has a viral load suppressed. So for this patient, if I go as per our NACO guidelines, they encourage vaginal delivery or HIV positive patients because it is a known fact that very maternal morbidity is higher in HIV positive women compared to HIV negative women. And also with good ART, the risk of transmission has been already been highlighted earlier, less than 2% or 1% with good ART. So we are not getting much of an advantage. So as per NACO guidelines, it is they are recommending normal delivery. Where coming on to the Western guidelines like ACG and even for British HIV Association guidelines, they are recommending that for us the choice of delivery should be individualized for the patient. And while ACG also says that HIV viral load less than 1,000 copies per ml and good on ART, they should encourage with activity. But when it comes to British HIV Association, they are a little more stricter, and
they are offering cesarean for more than 400 CD4 counts, and even between 50 to 400 CD4 counts, which HIV association test, that is also an option. Now, again, this is based on certain literature that we have on the studies and meta-analysis, which have shown that, conventionally we all have thought that cesarean increases the risk, but we need to understand that these are studies, older studies, and you are not using triple ARV like we are using now. So with these good drugs and with good counts, there is a reasonable chance that it is given with even with normal delivery. So it's a difference between 2% and 1%. So I think for most women might opt again to give offer to the patient. As regard leaking is concerned, risk of leaking is concerned, yes, we all know that with leaking we are worried about the risk of infection. Again, the previous studies that have been there, those are on patients who are not being put on ARV drugs. So our current patient who was on ARV drugs, the studies have shown that even after 25 hours of taking, a patient who is very good virally suppressed on ARV drugs, there may be no infection. So the general system is that you try to deliver them within 24 hours. That's the general system we follow.
Yeah, same, because here I want to discuss a counseling point, important counseling point of this patient, whether we want to allow her to deliver vaginally, allow her, or we have to opt for the cesarean. So how would you counsel her? On what basis and what important points do you want to tell her?
So, of course, first there would be risk of transmission to the child, mother to child transmission. So that we should assure her that with a good ARV prophylaxis, count is low. So she has a reasonable chance of delivering a baby vaginally without giving him the infection or him or her carrying the infection. So it reduces from 2% to 1%. So even with vaginal delivery, that's possible. Secondly, as I have already mentioned, that the rupture of membranes. So there's an increased risk, but that is more with high viral load. With viral load of less than 1,000, there has studies have found that there has been no association of spontaneous rupture of membrane with mother to child transmission. The other is that when you are given an option of cesarean versus vaginal, you need to understand that while the benefit rate is not statistically significant or not enough, there may be a slightly higher morbidity for cesarean section than sepsis and all. So she should take that also into account. Plus, she is a primary gravida patient who will probably plan more pregnancies, and you have to support the cesarean, like previous cesarean age, she might have a cesarean placenta, 3 years of visa. So you need to consider all those things so that she makes an informed decision. And again, yes, infant feeding practices. I'm sure if she has a good antenatal coverage, she must have been counseled about that. But this also is a good time to sensitize about what would be her infant feeding practices, whether she wants to do
That we are going to discuss in detail. Yeah.
And then infant ARV prophylaxis should also be sensitized, and contraception should also be sensitized.
Yeah, so most important point in the counseling, we have to explain her in detail that because you are well suppressed, your viral load is well suppressed, so you can be given normal vaginal delivery, though you have come with a leaking. We can explain her that there is a need of the augmentation of the labor. We can expedite the delivery, and if Bishop score is not good, then we can consider the cesarean if she's too worried. But we have to tell her that the vaginal delivery as well as the cesarean has the almost same risk of the infection. So she can be given vaginal delivery if all the factors are all right and Bishop score is good. So, and there is no difference between the cesarean, rather cesarean has a more morbidity. So another question, how long, as you already said, you can wait with a good viral load suppression for the 24 hours. But still I would like to say, I don't know what's Dr. Mani's opinion. I would like to say if Bishop score is not good, then unnecessarily we should not wait for and prolonging the labor. We should immediately expedite the labor, augment the labor, and we can explain her if you are not progressing well, then we can consider the cesarean at the earliest.
See, it's like obstetric patient, any other lady, but since she came with the prom actually, and she's a second gravida, and the bishop, like Dr. Chandra said, is poor bishop, then maybe I would tilt in favor of cesarean along with her counseling for sterilization, because she was a second gravida. She's a primary.
Yeah,
Suppose if she was a second gravida, then I would tilt towards cesarean. But in the primary, we can wait and try to augment and slightly wait in this patient. But that's definitely not a too prolonged trial. Unless
So I would not like to leave her for 24 hours, definitely.
Within 24 hours.
So if delivery has to be done within 24 hours of people, you don't leave her. You have to augment it as long as
And follow the labor protocols. And if she's not progressing, then a slightly early intervention would be here in this group.
So just a question to you, are you believing that HIV positive women normally?
Dr. Mani is delivering,
In the initial era, we were counseling, naturally we were biased towards cesarean, we did not have a lot of studies. But since last 7 years, whatever all I had, only one had a cesarean section left to for obstetric indication.
She has been.
Infrastructure training, more than, I mean, the counseling and all, the obstetrical implication.
Yeah, it's basically the sensitization of the residents who come to us, which is there. Yeah.
I think that is the most determinant factor in delivering.
Yeah, absolutely.
The staff has to be diligent and they have to be good counselors themselves actually, because the residents are there on the ground field. So we need to teach them first actually, our team basically.
Yeah, now there is less discrimination, but that is the most important thing. Yeah, especially,
We've
yeah.
forgotten about HIV now.
So, now we have decided to leave this patient for the vaginal delivery. You have started the same ART, you have given the intravenous dodovudine, and plus you have counseled everything. Now, what precautions would you like to take when you are leaving her for the vaginal delivery, or if you have opted for the cesarean, or this patient lands up in the emergency cesarean?
Like I've already been highlighted previously that whatever you decide vaginal cesarean, universal precautions which have been highlighted in detail. Then during vaginal delivery, I'll start from the first stage. You should minimize per vaginal examination so that infection, rupture, membrane, and for asepsis. Then, as ma'am has already said, that we would like to deliver her within 24 hours and not wait. So you should start augmenting labor depending on the patient you want to use. And
Gel, I think we should not prefer in the leaking PV, especially in the HIV positive. Yeah.
Then, if your patient has a fracture within days, you do not react to the that, so that is one thing you should avoid it. So, they say that if for obstetrical indication, you have to, the patient must go less than 50 cell count. If it's a less than 50 cell count, and let's say it's a fracture or something, not for this patient, you may consider subject. So, obstetric indication takes precedence, but otherwise not. And non-invasive treatment has to be more of theoretical. I don't think any one of us is using it. Coming on the second stage of labor, though it is said that you have to support peritoneum mass, it's a very thing that you say you have to avoid routine and physiology. Now, again, this is based on studies which were done in the pre-ART era. So that is the data we have. But they say that if you have good cell count, and British HIV Association, if it is less than 50 cell count, then they are giving a green signal anyways. But even I think for you have to assess it objectively. If you can deliver without it, it's not well and good. That is it. Again, instrumental delivery should be avoided. Again, there's a political risk of infection. These studies are again older and not people have get studies now. So as you should definitely avoid. And if indicated, they find that courses delivery is cheaper. But again, for less than 50, I think we give a good signal. British HIV Association is vocal about it. ACOG, they are not mentioning, but they are
But
saying
more absence with the ventules, so we should
we should avoid.
We should avoid. Yeah.
As far as third stage of labor goes, they encourage delayed cord clapping because they will see that even with 30 to 60 seconds delay, there is a risk of decreased risk of fetal anemia, and there's not much, there is no significant increase in the risk of fetal infection. So they're encouraging delayed cord clapping, and when you're handling the cord, you should use a glove hand, and then you can cover it with a gauze on hand so that the blood doesn't splash on your face. So that is something that you can do. And the third is again the same, so there's a risk of interaction with some ARV drugs, and I don't think many of us are using the third now.
Oxytocin, yeah. So there is no such contraindicated.
But with few drugs, there's a drug interaction,
Yeah.
SPIP, but anyway, we are not using the third in any case. So I think that is important. Then coming on to the cesarean part, again, using cesarean, you should basically avoid, you have to understand the higher risk of sepsis and morbidity. So good antibiotic prophylaxis is there, good aseptic technique, universal precautions is already highlighted. An important point about ARV drug is that you should ideally should not discontinue using ARV drug even for 24 hours. So if possible, I'm taking my patient to cesarean, you should give her the sip of water whenever you feel feasible. Avoid skipping the dose. And in case you have to skip, this is you skip all. Don't skip like 1 or 2. Skip all. So this is a drug combination, so you delete all. And then start as soon as possible. So that is important.
rather they advise before the cesarean, planned cesarean, or even the emergency, give the IV zidovudine. We don't have IV zidovudine here, but we prefer to give the 300 milligram of zidovudine orally. We have been giving, and plus the ARV, whatever she is taking ARV, that should be continued. And plus the antibiotic cover should be given, especially in cases of the cesarean.
Yes, ma'am. And while you're doing the technique, again, as I already highlighted in the previous talk, that you should use not full instruments.
Yeah, that we already discussed. Yeah, universal precaution, that one has to be very careful. So important points in the vaginal delivery. Points in the vaginal delivery, that patient should continue the ART, and if she's for the vaginal delivery, then partogram should be maintained, and whenever there is a indication, we immediately decide the emergency cesarean if she's not progressing well. Okay, and plus we have to be careful, as Dr. Garima has already said, the ventouse should not be used, or and even we should avoid the episiotomy, and even the electrode. If any intervention, an electrode should be avoided.
And then while handling the baby pediatrician or obstetrician, they should use gloved hands until all the secretions are wiped out, because that is also the
Yeah, and suction of the baby should be avoided unless it's required. If there is a meconium, then only you use, and the pressure should be used less than the 100 milligram mercury. That should be used for the suction. And plus, if the cord clamping, she has already said, if viral load is well suppressed, then you can wait for the 30 to 1 minute. But when the viral load is not well suppressed, then you can decide to do the early cord clamping. Because that is very important. Viral load is very important. If it is well suppressed, then you can do. There's no problem. It's like a normal patient. Okay.
I would just like to add here, like in viral load, when the majority of the government sector, we don't have the facility of doing every time. So what we see is the onset, when did she contact HIV, and the partner
And
is
how many weeks she has
how many
taken the-
weeks she has taken ART, accordingly we decide. And like Dr. Garima mentioned, the risk of anemia. We are more worried about that because the ladies are already anemic, and fetal anemia, a child may not have the transmission because she was an ART, but then the child will die of other problems. So we have to weigh actually and then decide.
Yeah, absolutely. And one more important, if you are doing the elective cesarean, then they say that you wait for the baby to, come through the incision, pure incision, then you rupture the membrane rather than you are rupturing before, because in otherwise normal cases, we are rupturing the membrane before taking out the baby. So just let the baby's head come out and then rupture the membrane. Yeah.
But technically,
Yeah, it's difficult. Yeah, but they say you avoid, do this thing. If it is possible,
push the baby and then rupture the
push the baby and then rupture the
They
membrane.
just give us slight
Yeah.
support.
So thank you, Dr. Garima. So we are moving to the another case.
Bigger incisions for that. Required. So moving on to the next case, she's a 32-year-old female, a second gravida now here, 39 weeks, unbooked patient, no antenatal whatsoever. She comes in active labor to us. She had leaking since 2 hours, and all blood tests were sent, everything was done. And like we have rapid kit, so we did a rapid kit, and she came out to, that was equivocal. Next day she delivered. Now next day her report comes out to be positive. So what do we do next? I would like to throw this question to Dr. Tripti.
Thank you, ma'am. I almost feel like the police, movies में दिखाते हैं सब कुछ हो गया तो आ गए.
Last patient last way,
Yeah, so it's a nightmarish thing, but then as obstetricians, we know that these patients are the ones who try us for, our patients for everything, not only HIV. So now we can see that she fits into the category of high risk for every reason. She's unbooked, untreated. We have no idea about her CD4 count, viral load, no reports. She could be having, unprotected sex all through her pregnancy. She has leaking and she delivered more than 4 hours later, and it was a vaginal delivery. So yes, now we have to take care of we have to think about the patient here, we have to think about the baby here, we have to think about her husband and the other child also, and also about any, in case, inadvertent exposure to the healthcare workers also. So immediately we would send blood for all her routine tests. We do it otherwise also, but here a confirmatory test also needs to be sent. And involve the physician and inform the pediatrician about this catastrophic event that has happened in our labor room. And we have to start her on ART immediately because we know that the risk of transmission during this peripartum period and when she would be breastfeeding is very high. There's about 20% or 10% during pregnancy, then about 50% during labor, intranatal period, which we have missed. And now during this postpartum period, another about 30% chance of infection. So there are so many points that we have to take care about, and these needs to be informed, a very thorough counseling to this patient. She has to ensure, adherence to program. Precious time has already been lost, and she has to be told this in detail that now whatever the further risk that she can bring down by strictly adhering to the ARTs. And again, decision to breastfeeding, the WHO guidelines and all, they do advocate. We are a low resource country, and obviously this patient was unbooked, no test. So we can know that for her, breastfeeding would be a very good option. So, but then she has to be told that this is going to increase the transmission and ensure no mixed feedings. And we have to tell her to take care of the nipples. There should be no cracked nipples, no mastitis. The antibiotic prophylaxis has to be continued. And we have to talk about contraception and pap smear later on, and also check for other STIs also.
So what contraception would you like to give her, Dr. Chittu?
Now, again, for these patients, it's very important to have a dual method, a double contraception. Barrier plus effective method that would prevent pregnancy also. So there are barrier contraceptives are, of course, the most common ones are the condoms. But again, with condom, there can be spillage, and plus even the female condoms have come up. They are good, but then they are more expensive. Plus the female condoms in them, the vaginal exposure to semen is much less. But the most commonly used one is the male condom, so it has to be advocated to them. Now coming to the diaphragm, windows and caps, they are not recommended because there's a large area of the vaginal mucosa that remains exposed to semen.
Yeah.
And plus they might cause microtrauma during.
What would you like to offer her now? She's there.
Yeah.
Second, she's delivered, she's there with us. So what would you like to give her?
I would like to tell her about all these. It has to be counseled to her, no, ma'am. I mean, the barrier method has to be used.
Yeah,
The
that is there.
male
What's the
condom.
informed choice? Because as you said, the failure rate is high.
Yeah.
So is that a solution for her? What else would be? It's an informed choice. We offer a
Yeah.
basket of contraceptives.
Yes,
It's a
ma'am.
choice. Barrier method, yes, it has to be there. Plus, what else would you like to?
Ma'am, at this time, we can offer her the IUDs and all these methods. It has to be given because the long-acting methods should be preferred in this patient. But again, there are issues because we don't know about the other status of this patient.
Basically,
Ask one question from you also. PP IUCD, postpartum IUCD should not be preferred in this case. I don't know.
Yeah, that is why I was a little, because WHO says we have to be a little cautious in these patients.
She just delivered.
yeah.
Yes.
So
that
just
is what-
delivered patient, Dr. Garima is there from a public sector.
That is why I was
And
also a
there,
little
so,
reluctant in going to that.
If you see the
From
MEC
GTB.
criteria, yeah, you are also from
Yeah.
GTB, we are 3 from the, so what do you use? Do we use PPIs in such patients or not?
See, barrier,
Not
you
Shweta?
are going to tell her, okay, use barrier whenever she is having the relation. But right now, whether you would counsel her for the PP IUCD.
Actually, there's no that contraindication to nahi hai.
And no, this patient especially
Yeah,
because
she has delivered.
she delivered an high-risk patient because she has not taken any ART. Just now
Yeah.
her report has come positive.
So we don't know the viral load, the amount
We
of
don't know
infection,
anything.
so better not to use a.
So we see the MEC
it's a
criteria. Here comes the MEC criteria wheel into picture.
In fact, we can offer her progesterone only
Yeah.
contraception
Yes,
first
yes.
because she's a breastfeeding and a lactating
And
mother.
we also have
That's it.
Centroman with us in our
Yeah,
country,
and
which has
Centroman,
come
yeah.
into India wheel. It has been
Yeah.
released, launched by the government of India.
Yeah.
India wheel has been released. Centroman is a very good option because it
Yeah.
is non-hormonal also.
Non-hormonal,
It will
yeah.
not interfere with her ARV as well.
So these are the two
And
most
plus,
common.
I give her when she goes home. Actually,
Yeah.
I'm giving her, sending her, and obviously, then after 6 weeks, want to switch over, I can put her on MPA, and then I would know her status
Long
also,
acting, yeah.
the viral load and CD4 accordingly. If she opt for an IUCD, then subsequently,
We have
again and again for adherence to ART and many other. So that time we can keep changing her contraceptive choices.
Yeah, so absolutely. So going by the scenarios of our all four our cases, because we're running short on time, we have one more question to discuss. So the basic aim is like universal precautions. Like this lady, she came unbooked. HIV pata hota hai, so everybody takes care. Status nahi malum, so residents and we all tend to relax. No, a lady regular antenatal testing after of cases. And PEP, like not handling all these precautions mentioned, special precaution during cesarean, have to be done in 100% of the cases. And contraceptive, yes, counseling we have to do, and it's all about counseling HIV patient, positive patients to carry forward adherence, which is more important because this ART will be for lifelong. That has to be reiterated to us. I invite Dr. Chandra to take over the next questions. Thank you, Dr.
So now we are coming to that's PPP model. So Dr. Morvi is here. I would like to ask her because we don't know all. I think in the morning we have gone through that. What is a PPP model? But in detail, she can explain us. So Dr. Morvi, what do you mean by PPP model?
Thank you for the opportunity, ma'am. So PPP basically stands for public-private partnership, like we are all working with. We are working with the government as well as the private sector in collaboration. It's a unique model that utilizes the capacities, the skills, and the resources from each of the partner. It helps provide better care, support, and treatment for HIV positive patients, and basically the pregnant women that we are dealing with here in Sanctuary. This model is formed to increase the coverage and to reach a large number of pregnant women to work towards elimination of mother-to-child transmission of HIV. The partnership also brings out the cost sharing and consolidate the efforts of saturate identification of all the positive pregnant women to provide comprehensive services to them.
Thank you, Dr. Morvi. There is another question. Why to engage private sectors?
Ma'am, it is very important to engage the private sector because most of the deliveries in India are also happening in the private sector. So since we are dealing with achieving the goal of to end epidemic of AIDS by 2030, that is why engaging private sector is also important so that we do not miss a single pregnant woman and everybody is tested and they all come into our cascades. That is why it's important.
Okay. What is the role of SAPI in this? And what is SAPI? What is the full form of SAPI? And
SAPI is an NGO, it's a non-governmental organization. Stands for Solidarity and Action Against HIV Infections in India. We basically work for the 3 projects, but focusing here is Svetna project. So we are working for elimination of mother-to-child transmission of HIV. That is PPTCT, prevention of parent-to-child transmission of HIV. What we do, we engage both the private as well as the public sector together, and we follow up the mother, the pregnant woman, and her baby for 18 months. We follow them for ART adherence, for testing the baby, which is done 4 times between the 18 months, that is 2 months, 6 months, 12 months, and 18 months. Then we also help them get linked to social protection schemes and what benefits do they get from the government of India, how can they get their medicines on time, and where are the ART centers which are very near to them, where they can go, and counseling services which they can receive free of cost and treatment from the government facility. And if by chance it's a private facility from which the pregnant woman needs to take the services, we go liaise with them. We try and convince the doctor to do a delivery. We pre-book them there in the private facility so that the doctor is not at risk as well as the patient is not at risk. This is what our job is.
okay, thank you, Morvi. You explained in detail. Yeah, so for the PG is important. You see PPTCT, prevention of parent to child transmission, and MTCT, mother to child. Parent to child and mother to child is the same thing because initially they used to say mother to child, but later on they said no, father is also equally responsible. If father is positive, then the parent to child transmission. Okay, so PPTCT is prevention of parent to child transmission. Otherwise, they will be confused. So
Yeah,
now I invite Dr. Mani for the some of the
So in our ICTC setup, which we have two categories. One unit is PPTCT, which is attached to the OBGYN department because take care of private women. And second is the ICTC part where any walk-in client can come or non-pregnant male and female are taken care of. So basically what I want to summarize, take home key objective is like whenever, when we are dealing with pregnant women, whenever a lady comes to us, we are doing testing, 100% testing is to be done. If she directly drops in labor, then all units must have rapid testing kits with us. At least we can do a rapid testing kit, which has a high sensitivity. So we can do that and ELISA can follow later on. But if ELISA rapid test comes out to be positive, we know we can immediately start her on prophylaxis and give the prophylaxis to the baby as well, and mother put on ART, and all the staff is also aware that is there. So the key objective remains is to prevent the transmission, and we need to take 100% universal precaution in all the cases coming to us. 100% adherence has to be there. Our surgical techniques, our basic surgical skills have to be very good, like handling the needles. We should not be doing for any surgery. We should not be doing that. And one more point is counseling is very important here, and the couple counseling is very important. And if the need be, if they want the family to involve in family counseling, adherence to her ART regimen. This opportunity has been given to her. She will be getting it lifelong, free of cost. She has to adhere to it, and she has to have safe feeding practices have to be told to her. In our country, we are promoting breastfeeding, and has been seen by almost all the studies that top feed in our scenario, because we are low middle income country, and what we have seen is mixed feeding happens, or the feed which they make is not good. Like initially when we started, we have delivered around 50 HIV positives in the last couple of years, and what we saw was those who breastfed the baby, none of the baby became positive at follow-up of 18 months, except one patient who had mixed feed, because they did not disclose to the family, and the problem occurred कि breastfeed क्यों नहीं करा रहे, top feed क्यों करा रहे हो, ये करा वो करा. And those who top fed their baby, ARV मिला, पहले तो cesarean नहीं करते थे, cesarean हुआ, top feed भी दी, but the infant did not survive beyond 1 year because recurrent diarrhea and pneumonia. We lost those babies. Those who breastfed, none of the baby was lost, except one because of mixed feed. So for our scenario, breastfeeding is a very good option. Start ART as early as possible. Take universal precaution, protect yourself, protect the baby, and counseling for adherence lifelong. So that will go a long way in promoting and our services and preventing. We don't want a single child, neonate, to be infected, and we have to eliminate this pediatric neonatal HIV. Thank you all very much. If any questions, we will be happy to take that. Yeah, Dr. Sahu is expert. Dr. Gangadhar Sahu is here, so we would like to hear his expert comments.
Okay, thank you, madam.
So can you hear us, sir? Yeah, welcome, sir.
Yes.
Yes, sir.
So now it is my turn.
Yeah, we have talked enough.
Thank you, madam. So after listening the observing panel, so I am totally spellbound, and thanks to the esteemed moderators, Mrinalini madam and dear Chandra madam, and dear panelists. So my way of thinking about this problem is that my principle is prevent the preventable, delay the inevitable, treat the treatable. If you can cure the curable. If it cannot be cured, must be endured. That is the basic principle of treatment that I follow. Therefore, since it is eliminate the transmission from the parents to the child, it is a very good term or to promise to make, but on the field, how far it is practicable, that only that is to be seen. So if we focus on that, I will think of first primary prevention, secondary prevention, and tertiary prevention. So primary prevention in this case particularly is the premarital counseling. If anybody is positive, ask them not to get married to the, whether it is a love marriage or arranged marriage, whatever it may be. Second is preconception counseling. So just before pregnancy, if they are tested, then you can, according to the viral load, you can give them treatment. Then once they are fit, allow them to conceive. Therefore, screening is a must in pregnancy, as we are doing always. If during early pregnancy it is positive, as we have discussed, that per se, HIV is not an indication for medical termination of pregnancy, but a liberal decision for medical termination of pregnancy can prevent the parent to child transmission. That is my view. So second line of prevention is early diagnosis and treatment. That has been vividly discussed different case-wise. If positive, what is the viral load and what are the, I mean, ARV should be treated, how it should be treated. So those things, that protocol should be followed. And that too, the most dangerous part is the peripartum period, just before delivery, because of the preterm labor or something, PPROM, or even pre-labor discharge, whatever it may be. And during delivery, where the maximum transmission occurs, and following delivery. Even if the breastfeeding is advisable, still then there is a chance of transmission. So that is the most vital period that should be taken care of. So after delivery, so the final word is that, and I mean this antiviral drugs that should be continued lifelong. Madam already has focused it, highlighted it. Therefore, that should not be neglected. So lifelong ARV. Next is contraception. The most suitable contraception, if they are fit for, even for permanent sterilization, still then, I mean, barrier method of contraception is the best. There is the panacea for the prevention of infection. So permanent method of sterilization, that is only for the transmission sake, but for individual sake, barrier method is the best. And last but not the least, this HIV infection, that is AIDS, it is not a disease only for the person concerned or for the couple. To me, it is a psychosocial disease. So psychosocial disease, once you are treating, a holistic approach is mandatory. So holistic approach includes the health service providers as well as the receivers. So both sides, equal precautions should be taken for the prevention of contracting this disease. And last but not the least, $1 million question that was being asked by Mrinalini madam, also solved by her, that this question should be always kept in mind. When the status of the patient is not known, has come to emergency ward, or when a mother has come with a HIV report more than 3 months back, it was being done, then treat it as HIV positive unless otherwise proved. Thank you very much, madam, for giving me this opportunity to exchange my views and interact with all of you. So I enjoyed till now the panel the most. So I wish this sort of relationship should continue between me and you. It is long lasting.
Thank you very much.
Thank you
sir,
very
for
much,
your
sir.
expert comments, sir.
So you have summarized it very beautifully, and I thank the organizer for giving me this opportunity. Thank you very much. So we end this session here now.
And thank you to all our panelists also. We have very good discussion. Now we can go for the cup of tea. Now I think we all are tired because we have to listen other lectures also. So we have to again charge.
So there's a break for everyone for 10 minutes now.
Sandra ma'am,
Hanji sir.
sir, where is my cup of tea?
Sir, yeah, we are missing you. Sir, now you have to take cup of tea at home only.
So everyone has at home a cup of tea or hot tea wherever they are.
Yes.
Already I have enjoyed the cup of tea through your discussion. Thank you very much.
Thank you, sir.
Thank you so much, sir. It was a pleasure.
So we will be here.
Thank you. Till he gets the presentation out. First of all, let me tell you, nobody dies of HIV these days. There's a lot of the stigmatization has gone, and it is a treatable disease. Okay, so there are huge lots of drugs available. So there's nothing scare. I think we need to get the stigmatization out. You have already discussed some of the vital aspects of the perinatal HIV transmission. Yeah, that's fine. So we'll be talking about the perinatal HIV exposure, primarily the neonatal care. I may overlap a little bit about the treatment modalities in the pregnant women. I know they have been discussed earlier. We'll be discussing about the primarily in the neonates once they are born of HIV positive mothers in our scenario. So we would ideally have the mothers tested during pregnancy so that we know their status and they are started on treatment right in first trimester or second trimester. So there's a drastic reduction in the perinatal transmission, and that's the beautiful thing to take care. So I'll be discussing about the neonatal prophylaxis for the babies and a little bit about how you diagnose early infant diagnosis, whether they are uninfected or they are not infected. And I think the breastfeeding part will be taken after this lecture, so I will not get into the nitty-gritties of that. Let's have a look at this slide. This is data from the NACO. This is the latest data, 2017 data. So that means out of the 2.14 million people who were infected till 2017, about substantial 7% is the pediatric population. So that's around more than 160,000, 160,000 children. So this is primarily perinatal transmission. So some of them are because of blood and blood products, in spite of the rigorous blood, testing being done by the ELISA or by the other, by PCR, still we are missing certain, or they are not being tested. So after 1994, there has been a sort of, there's a law that all the blood banks have to test the blood for HIV, HCV, and anyway, so our aim is to substantially reduce this 7%. So we should not have any perinatal transmission. Way back from 1994 till now, there has been a drastic reduction in the perinatal transmission. These are the various trials which have been conducted. The earliest trial, the ACTGO trial, we showed a significant reduction, about 67% reduction. So that gave us the hope in 1994, just a single drug in pregnancy substantially makes a difference. So if the mothers are started in pregnancy just on a single drug, to 67.5% reduction in perinatal transmission will be there. Subsequently, there have been other studies, the short-term studies, the 1 month, the Thai study, the HUNET study, the nevarapine, which we are a little too biased with this nevarapine. It is not that wonder drug, just giving a single drug to the baby. Ideally, we should detect them early in pregnancy in the first trimester, start them on triple drug. So these days, the modality is to treat them with 3 drugs, not with 1 drug. So you have already undergone, I think, Dr. Chandra, have you discussed these scenarios earlier in the morning? Okay, so you have discussed these scenarios in the morning. This is a classical scenario where we have an HIV infected an antenatal mother coming in the pregnancy, in the first trimester being diagnosed positive. So what do you do in that scenario and how do you manage? You have already undergone. So my concern is about what are the steps of the management for the baby. Second scenario, which you must have gone through, is that this 30-year-old lady who known case of HIV with 3 months pregnancy. She was diagnosed HIV infected 5 years back, and then she had received a single dose nevarapine. During that, her CD4 count is this and that. Then what do you do in this scenario? Third scenario would be something like this. This is one more lady about 7 months back. In the last trimester of pregnancy, she was diagnosed positive, and then she has been given history of being provided some medicine. We don't know the details. She is coming in the labor room for the first time, and she is reporting back, with 5-month-old breastfeeding. So what do we do for the mother? She is already infected. So these are various scenarios which will be seen. So these guidelines are the WHO guidelines or the NACO guidelines. They are not the CDC guidelines. They are not technically the scientific guidelines what we follow today. But this is still the sheet anchor of our national program. So you start them on a triple drug combination, which I have highlighted in the red. So these days, most of the mothers get tenofovir, they will get lamivudine, and they will get everolimus in pregnancy. So this is the regimen they get, either depending upon what is their supply in the government supply. So this is earlier we used to give them everolimus or nevarapine, but these days there is ideally we should not start nevarapine in pregnancy because there are a lot of issues. So that's why people are using everolimus, or preferably a dolutegravir should be used. So dolutegravir is one more integrase inhibitor which we use in pregnancy, so they can be very safely used in pregnancy. So earlier we were not using dolutegravir in pregnancy, but there has been a lot of data which has been published from South Africa. There was a little concern about the neural tube defects in the babies, but they have looked at their own data from South Africa and found out that there is not substantial increase with use of dolutegravir in first or second trimester of pregnancy. So dolutegravir is more or less safe in pregnancy. Still, it is a class C drug. So this is a part of anti-HIV armamentarium during pregnancy. So you can use either zidovudine, lamivudine, or dolutegravir. The best thing would be to use a FTC, 3T, FTC, lamivudine or 3T, lamivudine or FTC plus dolutegravir. So that's what we'll be using during pregnancy. Now concerning the newborn. So once in ideal situations, we would have the mother should get their antiretroviral therapy. So if she presents during the pregnancy, I mean in the labor for the first time, so you have an option of giving them oral zidovudine or a combination of zidovudine and lamivudine during the period of labor and then subsequently to the baby. So the usual steps of the care for the baby that will be done, the cord normally or standard is to do a delayed cord clamping, okay? But here we would not really like to do the delayed cord clamping in the scenario where we don't know the mother's infection status or she is diagnosed recently positive at the time of labor. So, and there is a lot of issue with the breastfeeding. So ideally, once we counsel them about the breastfeeding, we should initiate feeding within first hour of birth according to the preferred choice. So that's a little separate issue whether breastfeeding will be given or alternative feeding will be given, depending upon the mother's viral load, the treatment, the socioeconomic scenario. So on case-to-case basis, we need to discuss about the breastfeeding. And the baby should be started within first 12 hours of life on the antiretroviral therapy. So that's very important, especially for those mothers who are unbooked, who have been tested in last month of pregnancy or during labor. So these are the, if infant feeding and the risk factors for maternal to child transmission. So if the mother is infected while breastfeeding, so if she was negative during delivery and then subsequently because of the sexual exposure and she's still breastfeeding the child, that means she has an acute retroviral syndrome post-delivery, then in that scenario, there's a very high risk of transmission to the baby. So our target is that we should treat the mothers with triple drug combination so that they have undetectable viral loads. Once they have undetectable viral loads during pregnancy or during labor, that then only there will be no transmissible virus in the breast milk. So issue is with the cracked nipples, mastitis, engorgement. So if they are breastfeeding, we need to take care of them. Mothers who have advanced HIV disease, AIDS, very severely cachexic, we would prefer that they need not breastfeed. Okay. And then there are a lot of other mixed feeding is strict no-no. So you have to give them an option whether, well, you can breastfeed, provided the mother has to be on a triple drug antiretroviral. So these days, we will not advise them to breastfeed if the mother is not taking any antiretroviral therapy. So this is the risk of transmission. This is something accumulative data from different studies where they have shown that if there is mother does not receive any antiretroviral therapy and she is breastfeeding, there is a 30 to 40% risk of transmission. And there is no antiretroviral therapy and she is not breastfeeding, then about 20-25%. So you will see that 3 drugs and without breastfeeding, if you see the lower last column, the risk is 1%. So in our experience, we have also seen that all the mothers who were diagnosed in pregnancy started on antiretroviral therapy. They did not breastfeed, but here I don't want to advocate that stop breastfeeding. They be on top feeding, but the data shows that if they are not breastfed, so the risk of transmission is less than 1%. This is the sort of a key home message for everybody. So once the baby is born, irrespective of their mother status, they can be started on zidovudine or on nevirapine. So depending upon the institution, most of the government institutions are providing nevirapine to the baby. So they can be given about 4 to 6 weeks of nevirapine, or they can be given 4 weeks of zidovudine. So you have oral formulation of zidovudine available in the government setup, but unfortunately it is not available in the market. So you may have to reconstitute the zidovudine capsules or the tablets to make a suspension. So these are the doses depending on the prematurity and the birth weight. So the ideal dose would be about 15 milligrams twice a day for zidovudine. Same way, this is the scenario for a nevirapine. So if the government setup provides nevirapine to the babies, so they should be given nevirapine for about 4 weeks. And then once we know after 4 or 6 weeks that these mothers have received adequate antiretroviral therapy during pregnancy, we can stop the nevirapine after 4 or 6 weeks, then we retest them. So there's a strategy of retesting for the babies. So this is the algorithm. So because these are all indeterminate status babies. So if we test their cord bloods or the blood from the baby, it will be ELISA positive because that is the maternal IgG HIV reflection. So that is not the true scenario of the baby. So HIV exposure neonate, the community guidelines are that they should be taken a dried blood spot from after birth at 6 weeks of age, and then that is sent to the specific labs and analyzed for the PCR, because PCR will tell us a true picture. If the babies have 2 positive or 2 negative PCRs, then we can just allocate them whether they're negative or positive. So we do a HIV DNA PCR at 6 weeks of age. So this is merely a quantitative PCR. This is not a qualitative PCR like doing an RNA PCR. This is a cheaper than RNA PCR. So it tells us if it is positive, well, the baby is possibly infected. If it is negative, then the baby is not infected, but still we'll reevaluate them subsequently till we decide. But if we go from the antibodies, so we need to follow the antibody. So they will be antibody negative by maximum by 18 months if they are truly uninfected. If they are infected, you know by about 6 months or so that these babies are infected by PCRs or with antibody testing. So these are the, if you see the strategies, so if you have a mother with a low risk of transmission, that means you have diagnosed that mother early in pregnancy. So depending on whatever regime you use, it is not that I don't want to emphasize on a particular regime. So whatever antiretroviral regime she used, so the risk of transmission is very less. The baby needs just 4 weeks of zidovudine and it is stopped. But if there's a high risk of transmission, the mother comes during delivery or during labor, you don't know the status, she has been diagnosed HIV infected recently, then we should be giving 2 or 3 drugs to the baby. So that, because even if we presume that some viruses have transmitted during the process of labor, we take care of that. And then the scenario where the mother is with unknown HIV status and she is positive, so we have to put the babies on the 3 drugs, and especially the high-risk mother. So they are presumed that these babies are infected. So this is the update. Once we decide by 6 months or so, we can very well decide whether this baby is infected or uninfected, depending on the PCRs. So then these are the guidelines of treatment for the neonates and the children. So the high-risk neonates have to be on these type of regimes. So these are the newer medicines. We can still use nevirapine, what is used, that's what I have put it in the alternative, but the first line would be using a zidovudine, lamivudine, or a galtacavir for neonates. For children, it's like using like adults, abacavir plus lamivudine plus galtacavir. So you have a lot of these permutation and combinations. As generalists, for obstetricians and pediatricians, you may not really need this, but the dictum is that it is treatable. So HIV is not that, it is not a stigma. So the emphasis should be to diagnose early in pregnancy, in the first trimester of pregnancy, so that the mother is started on 3-drug antiretroviral combination and the perinatal transmission is drastically reduced to less than 1%. Thank you. Yeah, that's what we have. See, this is over the years, the scenario has changed. No, this 3-drug is for high-risk mothers. If the mother is, say, if you have diagnosed mother just in labor, she is HIV positive coming in the labor room.
Guidelines for me in the 2020, I went to, they said in the high risk, you give the
2 drugs. Yes, that's we give now. These are what I have taken you. This is the CDC guidelines. Basically, they are little different from the WHO and the NACO guidelines because these CDC guidelines are more patient specific guidelines, but WHO takes care of the African countries, underdeveloped countries, developing countries. So they have to look at the cost effectiveness.
6 months before that.
By 6 months, by 3 months, I can tell you whether the baby is infected or uninfected. Then no, one of the baby is not infected. If my 2 PCRs are negative, of 2 months apart, the baby is uninfected, the weight is fine, he is thriving well, irrespective. If we test 2 tests, we do 2 PCR. Then even if we do, I will do it, say 15 months, 1 ELISA. That will, at 15 or 18 months, I will do an ELISA. That will save the cost.
Because the parents are infected and they skip their medication.
parents will not, the baby will not get through the social contact. The baby will only get through the mother or through the breastfeeding. No mucus most of the time. So no, really, this is not to say they are not babies or they are hugging or kissing. That doesn't cause any infection to the baby. So we have not seen any baby positive in the scenario who was uninfected earlier and subsequently became infected in the household contact. It is not like hepatitis B. So hepatitis B can spread from towels infected. So it's more in transmissibility of hepatitis B is far higher than HIV. Sure.
I just want to add on that high risk pregnancies. Recently, the NACO guidelines they have sent an order saying that if like nevirapine is given to the HIV-1 patients actually, but zidovudine is provided to the HIV-2 patients. But then when the high risk pregnancies come, because it's taken into account for the high risk pregnancy, so a lady who comes like in direct labor room or postpartum part, then those babies should be provided dual prophylaxis immediately with zidovudine and with nevirapine.
Yeah.
And another high risk factor is that if the mother has not taken any ART from the beginning or less than 24 weeks, and then if the viral load of the mother is more than 1,000 copies, we take it as high risk pregnancies and we provide dual prophylaxis to the baby. Two drugs.
Yeah.
As per
From
NACO
the guidelines, see, that's the NACO guidelines are a little, but if we have a very high, with say mother with a very higher load, more than 1,000 copies, and or say 100,000 copies during pregnancy, she has not taken any ART during pregnancy. So the whole emphasis is treating the pregnant mother. Post delivery, this is just more of an eye wash than of real scientific basis. So the scientific basis is treating the mother in first, second trimester of pregnancy, when we will have a drastic viral load reduction below 1,000, the chances of below 150, 50. For cesarean, if your the scientific guidelines are, if your viral load is more than 1,000 copies, you can less than 1,000, you can opt for a normal delivery. Okay, but so we have already discussed that. Thank you.
Thank you.
We have to follow definitely, but the community part.
And for the DPS case and for the dry transport case, if the baby comes out in the first DPS as positive, a follow-up DPS is taken again. If two DPS is positive, then they declare as positive into the air.
Thank you, Dr. Dinesh, for giving such a lucid talk. And I think the crux of the story is that we have to diagnose the mother as early as possible, treat the mother as early as possible for the vertical transmission to go away, because 7.47%, or you can say with no RT and just no breastfeeding also, the rate is 25 to 35%, and which is very high. So thank you very much. Over to Dr. Ma.
It's my pleasure to invite the next speaker of the day, Dr. Kanika Chopra. She is the assistant professor in Obs and Gynae, Lady Harding Medical College. She's got the best medal for best postgraduate in Obs and Gynae, one traveling fellowship Foxy, with hysteroscopy courses, endoscopy courses, won many prizes in oral and poster presentation. And she's going to speak about the breastfeeding in HIV positive mother. Over to you, Dr. Kanika, for your scientific deliberation.
Thank you so much for the kind. So I am here to discuss another very important topic, that is breastfeeding in HIV positive mothers. So without wasting any time, I would like to continue. So breastfeeding in HIV positive mothers, why it is important? It is important because of a very famous saying by Pamela K. Wiggins, that breastfeeding is a mother's gift to herself, her baby, and the earth. So what was the history? History was opposite, because we all know that HIV transmission, it occurs in utero, peripartum, and postnatally by breastfeeding. Without intervention, the risk of perinatal HIV transmission is around 20 to 45%. But in a study by John J.C. et al. Way back in 1996, it was concluded that breastfed infants had higher transmission than non-breastfed infants, and the risk of transmission through breastfeeding was highest in early months of the infant's life. So, recapitulating the risk factors for HIV transmission through breast milk, we know that higher maternal plasma HIV RNA levels and breast milk HIV DNA and RNA levels are responsible for increasing the rate of HIV transmission through breast milk. The other is acute versus chronic HIV infection. This is 29% versus 14% in absence of antiretrovirals. Immunosuppressed mothers with low CD4 cell counts, presence of HIV drug resistance in the mother, mastitis and breast abscess, and mixed feeding, that is breastfeeding along with ingestion of solids and liquids during the first 3 to 6 months of life. So all these are responsible for increasing the transmission. So as an obstetrician, we should be well aware of these facts when we are seeing any HIV positive mother in the postnatal period. So what is seen over the years? For unfortunate mothers of several decades ago for whom no drug therapy was available for HIV, the risk of postnatal transmission through breastfeeding was estimated to be 50 to 30% higher than that of no breastfeeding. But following the WHO consolidated guidelines on the use of antiretroviral drugs for treating and preventing HIV infections in 2013, it was found that the risk of mother-to-child transmission may range from 5% to even less than 1% if we start ART for all our antenatal patients. Thereafter, WHO guidelines are released for HIV in 2021, where they recommend that tenofovir, lamivudine, and dolutegravir regimen, it should be started for all adults in resource-limited settings as the preferred first-line treatment. Why it is so? Because of the greater efficacy, better tolerability, and availability of a once-daily fixed-dose combination of this TLD regime. And this is now available in almost all the government hospitals. And a combination of tenofovir, lamivudine, and efavirenz is recommended as an alternative option now. Further, WHO recommended that infant antiretroviral use remains important as short-term post-exposure prophylaxis, which we have just seen in Dr. Dinesh's presentation, and even in settings in which maternal antiretroviral use is delayed or interrupted during breastfeeding. So as an obstetrician, we should know what all patients, babies, will be considered as high risk for transmission. So these are the babies who are born to mothers with high viral load, that is more than 1,000 copies per ml. And the other would be mothers who have not received any ART or received less than 4 weeks of ART at the time of delivery, and mothers who acquired new HIV infections during pregnancy or during breastfeeding. And we have discussed about what all treatment should be started for the infants, so I will not go into the details. Further, WHO recommends that for mothers known to have HIV, public health authorities should focus either on promoting breastfeeding fully and providing antiretroviral interventions to prevent transmission, or avoiding all breastfeeding and providing alternate sources of safe nutrition. So definitely in resource-limited settings, promoting breastfeeding with antiretroviral intervention is a better strategy and a key to prevent any mother-to-child transmission. So in an analysis of pooled data from studies in Asia and Africa, lack of breastfeeding was associated with mortality in HIV-exposed but uninfected infants. That is why it is very important to promote breastfeeding in all our HIV-positive mothers, along with ART adherence. So the same is, this slide also presents the same thing. The WHO recommends exclusive breastfeeding for 6 months in combination with maternal ART and short-term period of infant prophylaxis, optimizing the health benefits of breastfeeding for the infant. And subsequently, breastfeeding along with maternal ART with provision support and appropriate complementary feeding should continue without restrictions for even up to 24 months or longer, similar to general population. And why breastfeeding? We all know the breast milk is rich in immunoglobulins. It acts as baby's first immunization. and helps in reducing neonatal morbidity and mortality from diseases like pneumonia and diarrhea. Breastfeeding also decreases the risk of non-communicable diseases in later life. It supports healthy brain growth and development of the baby, and most importantly, healthy mother-baby bond. Alternative feeding strategies which were used over all these years prior to the fact that breastfeeding exclusive was recommended, it was the replacement feeding. Still, if our patient wants to go for replacement feeding, we cannot say them, no, you go for breastfeeding. So replacement feeding is an option if the mother is fully aware what all she should do for providing adequate nutrition to her baby. So avoidance of breastfeeding is a certain way to prevent HIV transmission by breast milk during the postnatal period. We have already seen in the previous presentation that it was less than 1%. So in resource-limited countries, replacement feeding is associated with other significant risks, which includes increased infant morbidity and mortality from various infectious diseases. The other, which was lately used, was shortened breastfeeding. So some studies suggested that shortened course of breastfeeding may be somewhat protective against HIV infant transmission, but it was not so, because in my second slide, I mentioned that majority of the transmission occurs during the early phase of the breastfeeding. So even if we shorten it or we continue it for 6 months, it is of no use. So, but with expanding antiretroviral drug availability in resource-limited settings, the risk of breast milk associated HIV transmission becomes low. So, it should not be advised. The other is the mixed feeding, which is usually the thought process of the mothers that breastfeed bhi kara dete hain aur thoda sa mixed feed bhi de dete hain, but that is not right. So if at all our mothers are following mixed feed, they should be explained that the pathogens and the dietary antigens in formula feeds, and even in the solids, if they are giving during the first 6 months, they can cause small sites of damage and inflammation to the baby's intestinal mucosa, which will increase the risk of transmission of HIV, which is HIV virus, which is present in the breast milk, to cross the mucous membrane and contact the baby's bloodstream, thus increasing the risk of infection. But it is also important that the recent ICO guidelines have shown that if the mother is mixed feeding, we should not say, no, you're doing wrong. We should explain them, go ahead and do breastfeeding exclusively and not do mixed feeding. But it is not like that the patients are said that you are doing wrong and the patient stops breastfeeding also and is not going on for the mixed feeding also. That will lead to poor nutrition of the baby. So counseling and follow-up, that is very important. So specific counseling may be needed to help new antiretrovirals during breastfeeding, and mothers will need practical assistance with latching. So breastfeeding counselors are very important and they play a very important role, especially in our patients who are HIV positive, so that they can comfortably breastfeed their babies, and if they have any issues, they report. So they may need advice and ongoing follow-up to avoid, minimize, and quickly resolve any postpartum breast or nipple problems, such as sore nipples, breast engorgement, or symptoms of mastitis. So this is one of a departmental study in which we studied the impact of WHO option B+ on maternal and perinatal outcomes in HIV positive women delivering at a tertiary care hospital, that is Lady Hardinge Medical College. And we found that they were like around 159 women in this entire study, and nearly 98.1% opted for breastfeeding, and only 3 out of 159 accepted as stop feeding as the mode of nutrition to the baby. So it was very nice that after introduction of this option D+, the mode of delivery changed to vaginal delivery, which is good for the mother and as well as the baby, and the breastfeeding is being promoted. So there are only 2 provisos I would like to highlight, and this is the take-home message as well. So mother must be meticulously adherent to their medication, and breastfeeding should be practiced exclusively during the first 6 months of life. Thank you all for your patient hearing.
Thanks, Dr. Kalika. You gave a very good take-home message. No mixed feeding, either exclusive breastfeeding or exclusive top feeding.
Yes, ma'am.
And definitely we must aim, as everybody is saying, in mother's treatment, that is more important. That will go a long way in preventing mother-to-child transmission.
Yes.
Okay.
I would like to.
Once after 6 months, she can feed her baby the replacement therapy as well as the breastfeeding. And she can, like a normal woman, if she's on the ART and she's adherent to that, she can continue breastfeeding even
Absolutely. So they can continue the breastfeeding like the general population.
What is the window?
Thank you so much. Thank you to the organizers. Thank you, Dr. Chandra, for inviting me.
Thank you, our experts, Dr. Latika ma'am and Dr. Malama. Now moving on to our third session, syphilis and obstetric complications. I would like to invite our experts. Dr. S.P. Biotra, sir. Sir is emeritus consultant general physician, specialist in medicinal care and specializing in cardiology and diabetic management. Welcome you, sir.
Well, thank you very much for inviting me on this very important session. Well, it's wonderful. I heard actually where we have seen changes when we first cases we have seen in the USA in 1981 when we see people in chains in US and how people used to behave. Like, as we were like astronauts when we were taken to the ward with all from the astronauts wearing them between to see what we have today. It's a wonderful thing. I have a lady for 21 years, who was positive, husband was positive, and now they said they want to have a child. They got a child, although it's no negative. The thanks of the thing and they're surviving. So it's like a chronic illness. Instead of they used to say it was a death, the death wasn't at that time when we diagnosed. But today it's like a chronic illness. Like any chronic disease, no, we treat and people, we hope they survive near normal life. Well, to this session is a session on syphilis again. We have seen a sea change in the people of syphilis. I don't know present modern generation how many patients of syphilis they must have seen, hardly any. And we actually have seen this is called gamma. Gamma, we have seen people will come in our medical college from villages and with a big hole over the roof of the mouth. Similarly, people coming with a big hole in the heart, like VSD, big hole. These are gamma, which we have seen, diagnosed, and any people coming in, we know, and then long way things have gone. And similarly, like unfortunately, as the present data goes, even the number of syphilis cases are rising in US also and other rest of the Europe countries. And this is going like thanks to a lot of antibiotics available, treatment is there, but still this is definitely a raise in the number of cases in syphilis coming, which are coming. And then it especially is in pregnancy and syphilis and in pregnancy, well, it's always screening, and I know in our hospital, the whole thing is in the first visit itself, they do the screening. And those who are prepared, who are little high risk vision, they do, I think, third semester also, and maybe post partum also they do. This is everything. Well, for discussion, without wasting more time, I invite Dr. Atul Gogia, who is the senior consultant in the Department of Medicine. He's not in that, he is specialized in infectious diseases also. And well, he's a member of so many things from like GIPMA, academic committee, and whatnot. One of the excellent persons, a physician, and a wonderful person who is in our hospital. And I invite Dr. Atul Gogia to come and speak on the syphilis screening and management in pregnancy.
Thank you so much. Good afternoon to all. First of all, thanks Dr. Biotra sir, who's always been pushing us to do all kind of academic and clinical activities. And thanks to the organizing team, Dr. Gujral ma'am and Dr. Chandra ma'am, to have me here today. So there was a lot of debate who should be talking about syphilis, and I assured that there is a lot of syphilis around. It is just about awareness and picking up and screening, which is very important. And there is a resurgence in syphilis which has happened, and that is primarily because of better awareness which is coming in, and HIV which is there, which we have discussed in the morning. So there are a lot of co-infections and infections which are there. And okay,
Yes, sir.
all right, thank you. So this slide is just a slide from published in 2013, way back, showing across the globe seropositivity of syphilis. And if you see, obviously, Africa, America, Asia, all the regions, especially the Southern America and African regions, there is quite a bit of prevalence, and there is wide variation in our big country like India, which a lot of areas having up to 3%, 4%, or 5% also in northeastern southern states, which is quite a high prevalence states are there. So there is a lot of variation across our country as well. And why it is important and why we are discussing this topic today is because it is a public health burden, as rightly highlighted by previous speakers, whether it was Dr. Kaul, whether it is HIV, whether it is syphilis. It is actually treating the mother, which is primarily screening and treating, thereby reducing the transmission to the fetus or the newborn. That is more important. So this from WHO 2012, nearly 1.5 million pregnant women are infected with syphilis each year. So the numbers are quite high, and half of these are untreated, and they will experience adverse outcomes. And I'm sure the next speaker would be touching upon that. There will be some overlap, but then, and so the maternal to child transmission of syphilis is very simple. So it is very simple. Actually, you just have to screen them and treat them. We, as Dr. Bharata rightly highlighted, this has been a disease which has been there for years together. Despite being the disease being there, still the public health programs, which have picked up now, but still the screening, which is simple and low cost, is not up to the mark. And we have to have more awareness and screening among the public so that we can increase. Just a quick word about syphilis for my younger colleagues who have probably not seen so much of syphilis. It is the Treponema pallidum subspecies, which is the causative organism, which is a spirochete, and it can be an acquired form or a congenital that is transmitted from mother to child, which can be early and late. Early is within first 2 years and late is beyond 2 years. Similarly, for the acquired form, there is early and late can be latent or tertiary or gamma and cardiovascular and neurosyphilis complications. So this was just the background so that you are aware. And it has primarily 3 stages: the primary stage, the secondary, the latent, and the tertiary stage. It is important because there is no major difference as far as the manifestations are concerned in pregnancy. So primary stage is when there is initial painless ulcer in the anogenital region, or it can be in the mouth or the rectal area, which is referred to as chancre. And generally it's 21 days, 10 to 90 days is the incubation period. So the secondary stage is one when the rash over the whole body with fever and muscle pain, which lasts for 2 to 3 months after the onset of the chancre, and it is followed by years of latent phase, and where the patients may not have any signs or symptoms. And that is the phase which most of us are encountering during screening, whether it is HIV or non-HIV pregnancy. That is where generally the latent phase is one when patients are seropositive, but they have no clinical signs or symptoms. So it is where you ask the patient, he or she has no signs and symptoms. So that is why. And so all other beyond 2 years, or when the history is not available, they are labeled as latent syphilis, that is beyond 2 years. And obviously tertiary is when it is an advanced stage, when it is gone on to involve all the major organs, whether it is cardiovascular or neurosyphilis or late benign. in the recent times, we've had, and I'm sure my junior colleagues have seen neurosyphilis. We've seen ocular syphilis in this hospital. So we've had 3 ocular syphilis. They are still following up with us. We have had patients with neurosyphilis. We lost 1 patient of neurosyphilis. So this is something we need to be aware, although obviously they were non-pregnant, but then a disease is when one partner is having it, so there is a high probability of the other partner having it. So important that we screen. And these are the pictures picked up from CDC just for the younger colleagues to have a look how the chancre looks like, or how the condomylita. And I'm sure I have not been able to add the picture, the last one, but one of the recently patient referred from gynae department only, one lady in general OPD was positive probably during pregnancy, and the husband turned out to be positive. The husband was referred and he had the classical secondary syphilis signs, which you can see in the palms and the soles. So we've had 2-3 of these patients who present with these kind of lesions in the palms and soles. So that is important because, and recently we have seen that patient. So just a quick word about syphilis. As I highlighted, that symptomatology, signs, they are quite, there's not much difference. The transmission generally is occurring between 16 to 28 weeks. And it is depending obviously like the viral load, it's depending on the spirochete load. If it is the primary or the secondary stage, then the chances of transmissions are high because there is a lot of doubling of the bacteria happening and the chances are there. And the syphilis, obviously, why we are concerned, because it leads to early fetal death, low birth weights, preterm deliveries, neonatal mortality and infection or disease of the newborn. And it is very, very important to screen because to prevent these kind of adverse outcomes, there is a huge burden. So that is why if untreated, a lot of mortality and morbidity is associated with this. There are 2 types of tests which are available. So one are the non-treponema tests and the other are the treponema tests. The non-treponema tests are the VDRL or the RPR test, which are good screening tools, but they may not be specific. So they may be false positive. Per se, pregnancy also can lead to false positive non-treponemal screening tests. So they need to be confirmed. So if you have a non-treponemal test which is positive, you need to confirm them by a treponemal test. That is important, whether it is a TPHA or TPPA. So the treponemal tests are the specific tests, and if they are positive, that means it is a positive disease. But the only issue is that once the test like a TPHA is positive, it may remain positive throughout. So despite treatment, there will be no change in its positivity, whereas the VDR RPR titers are which you need monitor to see the response of the treatment. So that is why both the tests are complementary to each other. So this is a slide directly picked up from WHO 2017, which, can I have a pointer? Do you have a pointer? So this is So very clear, the recommendation is very clear that all pregnant women for syphilis during their first antenatal care, strong recommendation, there is moderate quality evidence that they should undergo screening in settings with low coverage of syphilis. So these are guidelines as rightly highlighted by Dr. Paul, that WHO has to go for, public, private, both kind of settings. So low coverage, limited there. They also, when there is a high loss, to follow up, limited lab facility, their on-site tests should be recommended. So in our kind of a setup, we can afford, the patient is understanding, you tell them to get an off-site test, they come back after a day doing the test. But where you feel the facility is not enough, the patient may not come for follow-up in a government sector, they can do an on-site test there and then, and that is recommended. Even in low prevalence syphilis areas where below 5%, above 5% is high prevalence, below 5%, if it is there, also they say single on-site rapid syphilis test should be used to screen pregnant women rather than a single on-site RPR. So you can do a rapid test, which, it is just like a card test, which give you results immediately within an hour or two. And if high prevalence area is there, they say if positive, the first dose should be given there and there. You can keep on confirming it by an off-site test later on, but you give the first shot and then you decide later what to do. So just all pregnant women, first antenatal visit, can be repeated at third trimester, because first priority should be ensure universal antenatal screening. That is the most important. And at the time of delivery, obviously, if there is no antenatal screening has been done, or if there are spontaneous abortion, miscarriage, stillbirths with diagnosis of other STI, so your patient may have other STI, they should also be screened. And for commercial sex workers, every 6 months screening is suggested, and WHO suggests that screening and treatment should both be completed during the same encounter, because follow-up may not be possible in resource-constrained settings. So they should receive the test before leaving. If they test positive, they should be treated. Obviously, you have to look for penicillin allergy, and it is important that you screen the partner. That is very, very important before. This is just how the algorithm in a resource constrained setting should be there. If you have a robust program or not. If you do not have a good program, prevalence is high, you do not have enough sources, you do a rapid syphilis test and followed, give the dose. If you do not have the resources, but the prevalence is less, still you do a single RFC, and then you can give, based on the stage of syphilis, you treat. We'll go to the treatment part next. This is just again, this one slide is very important for the resident also to understand how the antibodies are going to fare. So you have early syphilis, you have late syphilis. So patient may present in any stage. So these are the non-treponema tests, the treponema tests. So if it is a primary infection, if it is an early infection, the non-treponema test may be negative very early on, and it may gradually become positive. But once you are in the secondary stage, it will be always positive. Usually in the early latent stage, it will be positive, usually positive in the late latent stage. And in the tertiary, if it is a very advanced, the antibody response may wane off and it may become negative. Going on to the treponemal test, which we were discussing, like the TPHA, it may become negative very early. Obviously, you may not mount. It will remain positive throughout. So that is why the tests like TPHA will remain positive throughout. May in tertiary stages become negative, but usually it will be positive throughout. And effect of treatment by stage of infection. So now important is how to monitor your treatment. So if the patient syphilis serology treated, it will become negative. It will become negative. If it is a very late latent, it may have a low response and it may remain positive in lower titers. And in tertiary, the results that they will not be much change in the serology of the non-treponemal test, whereas in the treponemal test, if you say it will remain positive throughout, and the tertiary, obviously, it will remain unchanged, whatever the thing is. So this is important for interpretation. And going on to the treatment, the WHO recommendation, pregnant woman, early syphilis, benzathine penicillin is the drug of choice. It is a cheap drug. A lot of us senior colleagues, and we have used in earlier times. It is difficult to procure these days, but it is available. And we are using it. One intramuscular injection once in early syphilis is comparative to no treatment. This is a strong recommendation. It should be given in pregnant with early syphilis, suggesting that once it is preferred over procaine penicillin. Obviously, it is easier to give also because it's a single dose. Procaine penicillin, you have to give multiple doses over 10 days. So the preference is to a single dose. And patients who have allergy to penicillin, so small fraction may have allergy. So desensitization and all this is difficult sometimes. If we are not able to do that, then erythromycin 500 milligram 4 times a day for 2 weeks, or ceftriaxone 1 gram intramuscularly once daily for 10 to 14 days, or azithro 2 gram once orally. So the problems is that these are drugs which have to be taken over a period of time in resource constrained setting, follow-up lag, it becomes a little difficult, and cost is an issue. So, but we have to understand that azithromycin, they will treat the pregnant lady, but not the child, because transmission. So it will not be effective in treating the newborn, because even if you treat that, so that is why penicillin remains the backbone. And obviously, doxy is a drug which we use, but in pregnancy we cannot use doxy. And ceftriaxone is an easily available drug, but again, then it's an injectable to be given over a period of 10 days. So that becomes an issue. And if it is late latent, if some patients may not give you any history, you do not know what is that. So you categorize them into late latent, late syphilis, that is more than 2 years duration, unknown stage. They will require once weekly 3 consecutive doses. So it has to be given once a week, every week for 3 weeks, and 2.4 million. So it is like available for the younger people. 12 lakh units as an injection, it is available. So 12 lakh in one buttock and 12 lakh in one buttock. That is what the prescription should say. With you have to do testing, because can cause anaphylaxis. So it is very important once they get the injection, and they will have to wait for half an hour or so to look for an allergic reaction. And the gap between the 2 injections, sometimes the patient may not come for follow-up, may miss. The gap should not be more than 14 days in any occasion. So that means it's a failure of treatment if there is a gap. And again, this shows that it is beneficial over propane penicillin. And obviously, azithromycin can be given in those settings. Just a simple for study and keeping a record for our OPD patients. So how to monitor? You can simple indicators, screening coverage, treatment coverage. So you just have to see number of women who have come for the first antenatal visit to the OPD here, and the number of pregnant women who were tested. So, you get to know how much screening coverage. That is just an indicator of how good we are doing as an institute. And again, treatment coverage, same number who are RPR reactive, and the numerator is number of RPR reactive women who have received treatment. So this just would give you, an idea is how good our program or our institution is faring in screening. And again, I'm not an expert in this, but still just guideline, all asymptomatic infants born to seropositive women should receive at birth a prophylactic single dose of benzathine penicillin, 50,000 IU per kg IM, whether or not the mother were treated during pregnancy. And the diagnosis, as we said, is very difficult in the children. So it is better that we, treat the mother and screen the mother, and because current treatment regimen for congenital syphilis involves parenteral penicillin, and hospitalization and cost and everything becomes an issue. And so it is very important for universal screening and treatment so that we can prevent this. Just a word about HIV, syphilis, HIV. They generally are, the tests are reliable. The same set of tests can be done. The only thing which sometimes happen is there may be a slower decline in the VDRL or the RPR titers after treatment in the HIV patients. And clinical suspicion and negative serology, we repeatedly further investigation should be done. And the risk of neurological ocular due to early syphilis does not appear to increase. So the risk of transmission remains the same, and it is just the careful follow-up which is required. Just 2-3 case scenarios, and I'll sum up. The first case scenario for this is a 26-year-old G3P2, 18 weeks gestation, history of venereal disease 4 years ago, has treated with 3 shots at that time. Current new prenatal labs reveal a reactive RPR with a titer of 1:4 and a reactive FTA. So what would you like to do in this? Repeat serology at 28 weeks or delivery. She's reinfected, treat her with penicillin, reassure her, none of the above, or I do not know, I'll ask for help. So anybody would like? So probably if the history is very reliable, that she has documented evidence that she's received treatment, you have the earlier titers available, and you are very confident that there is a decrease in titer, then probably yes. Otherwise, I would tell her that consider as reinfective and treat her with penicillin, because it is very important, because once we miss it, treatment is better because it's a reactive this thing. So very difficult. Reinfection, we will see, ma'am, it is 4 years ago. So depends on the documentation, how good she has kept and how sure she is. So we can consider it as reinfection or maybe probably reinfection, because 4 years is a long time. And so yeah, reinfection can occur, ma'am. So it is a sexually transmitted disease. So if you are partner is positive, it is not a lifelong antibody. You can have it in one pregnancy, you may be negative. So one lady we had here in the gynae department, she had a lot of issues. She was negative during first pregnancy. Now she is positive. Husband is negative, and there is a lot of fight going on. So she is very sure that this is false positive. What to do? So no, she is taking the treatment, but she says a lot of social issue. My husband is negative, I am positive, whereas I have no other sexual partner. So that becomes a social issue. So what will I say in the family? So this is another 18-year-old G1 P0, 10 weeks gestation, reactive RPR, titer of 1:2, reactive treponema test. She has no history of STDs, but her husband has just diagnosed recently with HIV syphilis co-infection. So what would you like to do? Repeat serology at 28 weeks, report, repeat at 4 to 6 weeks, reassure her, no further workup. I do not know. Yes, 1:2 can be neat reactive also. Yes. Yes, ma'am. So that is the answer. We would like to repeat it in 4 to 6 weeks to ensure that what is happening, because a very low titer, 1:2 is just about. So this is the last case, a 21-year-old G4 P1, 14 weeks gestation, non-reactive. Yes. Yeah. Many age we've had it. Non-reactive RPR, reactive treponema test, no history of any treatment, physical examination is. So what will you like to do? Yes. Non-reactive RPR. And she gives no history. So she is. So we would, yeah. So we would consider it probably latent kind of a disease, because she is not giving any history of treatment. And a treponemal test is positive, which is very specific test. So it can be a latent disease. Maybe she had sometime few years ago and she had no history. And so depends on the, yes, so treat karna hai usko. So just a quick word, test for syphilis in all women with history of adverse pregnancy outcomes, clinical disease or history of exposure to a person with syphilis. Screen all women for other STIs also. If it is positive, they need to, and especially HIV. So we have to counsel and get them tested for HIV also. And we have to make plans for treating the baby at birth and record the test and treatment facility logbook in the Women of ANC card. So take home message, all pregnant women should be screened. Sequential serological testing should be done using the same testing method. This is very important because the RPR testing, various labs give various reports, and it becomes very difficult to make the patient understand. Pichli baar to itna tha, abhi itna ho gaya, and there is a lot of issue. RPR. We are doing RPR in a hospital. A lot of outside labs, they just do VBRL logging without titer. So normally now I have to write that with titer, because we have to have the titer for us to know how we follow up the patients. And early and 20% of the primary syphilis patients may be non-reactive in both the tests. If it's very early disease, they may not be positive. And early and prompt treatment with syphilis can eliminate the MTCT of syphilis. Thank you so much. Thank you. Yes, ma'am. Yes. Negative statement. But if it is, yeah, one is 4 also we take as positive, and especially in pregnancy, the issue is of MTCT. That is the basic issue. If it is a non-pregnant person, then obviously you can repeat the test and counsel the patient. You have time at hand. That will remain positive. So there is a
any other question, or somebody have any comments? It's indeed a wonderful story, refresh all through syphilis of a long time. Thank you very much.
Thank you,
I think we need a big applause, all of us. Thank you. And now hand over time to Dr. Deepa.
So now it's my pleasant duty to invite Dr. Sumita Mehta, and she will be telling us about the syphilis and obstetrics identification. Can we have Dr. Sumita please? Dr. Sumita is a senior specialist and head of the Department of Obstetrics and Gynecology at Bobby Ram Memorial Hospital, Delhi. She's a highly acclaimed and expert in the field and also a Gangaram product. And I think lots of books and journals and special interest is preventive gynecology and high risk. Over to you, Sumita. Welcome to your alma mater.
Good afternoon, everybody, and thank you, Dr. Gita, for those kind words. And yes, I'm a product of Gangaram and proud of it. And it's always a pleasure coming back here. And now, yeah. Dr. Atul has actually covered most of the topic of syphilis in pregnancy. So he's made my task very much easier. So there might be a few overlaps, which I'll try to skip through. And I know I'm the last batsman standing between you and lunch, so I will try to add it up. So I will try to focus basically on the obstetric implications, though screening has been discussed in pregnancy and treatment has also been discussed. So very little is left for me. So I'll try to cover that. It's not going forward. Yes. Okay, so the classification has already been discussed. So it can be acquired, congenital. Acquired, of course, is early and late. Now, congenital is important for us as obstetricians because this is the one which is going to be transmitted through the mother transplacentally. And we define the congenital actually as early or late. So if the neonate is diagnosed within the first 2 years of life, we call that neonate has got early syphilis, early congenital syphilis. And if after 2 years, then it is called as late congenital syphilis. So stages, I'm not going to go into the detail of stages. What we need to remember is that stage of the patient is important because the load of spirochetes will depend on the stage of the disease. So if the patient is in primary or secondary stage of disease, now her load is going to be really high. And so there are more chances of transplacental passage of the spirochetes. So this is what is relevant to us. Now, the epidemiology has been touched by Dr. Gogia, and I just want to highlight that somehow, HIV has received a lot of concern and HIV epidemic has come down, but syphilis is something like a silent epidemic. It is really going high. Somehow the main focus has shifted from syphilis to HIV, which we really need to prevent now. If you see the Indian stats of 2019, only 33% women were tested for syphilis, which is a very pathetic figure. I mean, we are talking about universal testing of syphilis for all our pregnant women. The women who turned out to be positive from this 1/3 cohort were 0.1%. And even the ones who were positive, only 70% were treated. The rest 30% were not even treated. So, I mean, this is where we need to actually focus on. And that is why congenital syphilis is still a global public health problem. Why is it happened? The antenatal care has definitely improved. Our data shows that institutional deliveries have increased. They are close to 70%. But congenital syphilis is not decreasing. Why is that so? Because many of our antenatal visits are late. Patients are coming late. They do not have that much time of treatment for syphilis. That is why already the damage has happened. The infection has transmitted transplacentally. Secondly, maybe they did not get the test done. They might have got the test done, but they never came back for the report. That is why we are talking of point of care tests now, in which the patient doesn't need to come back. Then maybe the treatment was not available, or they might have been reinfected, especially if the partner was not treated. So that is why this syphilis is really a global public health problem nowadays. And if you see the figures here, between 2012 to 16, maximum adverse birth effects were occurring because they were not tested in ANC. And things have really not changed over these past 6 years. If you see the Southeast Asian region, even in our region, the major group is the ones who were not tested in antenatal. So please, that is what we have to remember. Test, test, test. Screening is a must. Now, when should we suspect syphilis in a pregnant woman? One, she might give you a history of contact with a person who was infected with syphilis, or if she gives you a history of a hydropic baby in the previous pregnancy, or she gives you a history of stillbirth, especially term stillbirth in previous pregnancy, that should alert us. Like, here is a patient who might be syphilis, who might have had syphilis in the past, and now she's latent. She has no symptoms, but serologically she might still be positive. So please remember that all pregnant women must be assumed to be at risk for syphilis. Indications for screening have already been told by Dr. Atul, so I'm not really repeating them. But at the first antenatal visit, you need to screen the woman. Now, the next is pathophysiology of how does syphilis transmit from the mother to the baby. So now mother has spirochetes in her blood, which cross the placenta, and then they infect the fetal liver, the amniotic fluid, as well as the hematological system. The fetus mounts a very robust inflammatory response because they actually, the spirochetes, they provoke an inflammatory response which is really very, very strong. And this response is seen mainly vascular and perivascular. And this results in end arthritis and fibrosis. So whenever you have end arthritis, means the blood going to the fetus is less, oxygen going to the fetus is less, and that is why you have more of FGRs and you have more of IUDs. So the pregnancy outcomes, almost 50% of women with syphilis would have an adverse obstetric outcome, which might be in the form of miscarriages, that too generally second trimester miscarriages, stillbirths, generally term late IUDs, are seen in 30-40%. And syphilis is the second leading cause of stillbirths globally. So this history should really alert us to, her history of syphilis. They can go into preterm labor, FGR, like I told you, and at times FGR may be the only, indication that this patient might be having syphilis. And of course, congenital syphilis. Once the neonate is born, he would be with the stigmata of syphilis. But the concern, the syphilis is said to be a great imitator of all diseases. So 60% of them might not have any symptoms, the infants, when they are born. And if you do not keep these infants in follow-up, you are going to lose. If you lose the follow-up, they are going to come back with the late stigmata of syphilis. And one important thing is that course of syphilis is not changed by pregnancy. Just one word about Jarisch-Herxheimer reaction, because it has got some obstetric implications. Basically, this is when you give the penicillin injection to the patient, she might have a hypersensitivity reaction in which she can have fever, chills, myalgia, arthralgia. What we are actually concerned about is that this can lead to preterm labor. This can cause fetal heart rate decelerations, can decrease fetal activity. So it is advocated that first dose, we can give it in a daycare. Let the patient be there in front of you so that she does not get this reaction. And if she does have it, we are there. So for convenience, I've divided the obstetric implications of if the fetus gets the syphilis in utero and then neonatal syphilis. So basically, like I told you, in utero syphilis happens because of transplacental passage of spirochetes. Now, the infection is detected at about 16 to 18 weeks. Though the fetus might be affected at 9 weeks, it's been seen by 9 to 10 weeks the fetus can be affected. But it is at 16 to 18 weeks that the immunological system of the baby, of the fetus gets, it's able to generate a robust immunological response. And then you start seeing the features of in utero syphilitic infection on ultrasound. Before that, it is difficult to pick up. So what are the factors which would influence fetal infection? Which are the mothers who would be, giving more of the fetal infections to their babies? One, it depends upon the gestational age. Spirochetes cross the placenta and infect the fetus from 14 weeks onwards. And as the gestation increases, so does the spirochete load. Then stage of maternal syphilis. Risk in untreated primary, secondary, or early latent is close to 80% because the load is high in primary and secondary syphilis. But in latent syphilis, the fetal infection is close to the tune of only 10%. Then maternal treatment. If you have not treated the woman during her pregnancy, then she has a 70% chance of giving the infection to, transmitting the infection to the fetus, and of course the immunological response of the fetus. So when you do an ultrasound on a baby who has been infected in utero, you would be able to pick up hepatomegaly in almost 80%. Fetal anemia would be there, which you can find out through the elevated MCA Doppler studies. Placentomegaly is a very important sign of syphilitic affection seen in close to 1/3 patients. Polyhydramnios, ascites, eye drops. Less commonly, you can have a splenomegaly, you can have cardiomegaly like you can see here, you can have a pericardial effusion. This is showing placentomegaly. So these are the features on ultrasound which should alert you that this is a patient where MTCT is happening of syphilis. And once you have treated the mother, you will see that most severe abnormalities such as hydrops and fetal anemia resolve first, while placentomegaly and hepatomegaly are more slow to resolve back. And important again, 10 to 12% ultrasounds can miss these features of congenital syphilis. Congenital syphilis, again, another diagnosis is placenta. The placenta of such women when they deliver would be large, pale, hydropic. And if you do a microscopic, you send these placentas for microscopic examination, and you will find that their terminal villi are enlarged, they're densely cellular, and basically you have inflammation everywhere. You have villitis, you have phenicitis. So because of the inflammatory response, there is inflammation everywhere, and you can do immunohistochemistry, and in which treponema will be seen. So that is again diagnostic of congenital syphilis. Now, neonatal syphilis has been divided into early congenital, in which signs are appearing within first 2 years, and late congenital syphilis, in which the signs are you see after 2 years, maybe over 1 or 2 decades. And these stigmata are basically the scars which have been induced by chronic inflammation. Won't be delving into the details of early congenital syphilis. What is important to remember is that almost all these infants would have hepatomegaly, 50% would have splenomegaly. You would have generalized lymphadenopathy in another half of them, anemia, leukopenia, thrombocytopenia, mucocutaneous involvement, very common, in which you have those rash which later desquamates. You have snuffles or rhinitis in these infants. This is hepatosplenomegaly. This is the typical rash which can be there in the infant which desquamates. We have the expert Dr. Dinesh Kaul here, so I don't really need to talk much about this. And of course, there are radiological signs also which are there again in these infants. I have put these slides just to highlight that once you infant you see, we are taking the delivery, right? And we see some changes in the infant, we should be alerting the pediatrician also that maybe, we need to look out for VDRL for syphilis in this patient. So these are all the investigations which are then done on the infant. And if we do not treat the infants, 50% of them will have the late stigmata, which could be any skeletal changes, saddle nose, bulldog facies, gentle abnormalities of Hutchinson teeth, mulberry molars. We all are familiar with the Hutchinson's triad, which consists of Hutchinson's incisors, interstitial keratitis, and deafness. We have Clutton's joints, in which we have basically pleurisy, you have fluid collection in the joint, saber shins. So all of this is preventable. All of this is preventable if we as obstetricians are screening the women and treating them timely. So all this is preventable. So how would we diagnose that now this baby has congenital syphilis? Because most of them might be asymptomatic at birth. Therein again lies the importance of us obstetricians, because the pediatrician will ask us that did you screen the woman? At what trimester did you screen the woman? Was the woman adequately treated? Have 4 weeks gone between her treatment, finishing her treatment and the baby delivering? So therein lies our role in informing the pediatrician as to what all the patient maternal medical history. And then of course the serological titers are compared, like Dr. Atul told you. We compare if the serological titers in the infant are 4-fold higher than the maternal titers, then we know that this is congenital syphilis, and it is not just passage of antibodies from the mother to the baby. So of course, for diagnosis in the baby, dark field microscopy or PCR can be done on bodily fluid. Again, like RPR quantitative is done. You do a full blood count because you know there can be anemia, thrombocytopenia. You do a LFT, you even do a CSF and see for cell and proteins level in them as well as RP are in them, do long bone and an opthal examination. So decision for treatment is taken if you are clinically suspecting that this baby has got congenital syphilis, interpretation of maternal and non-treponemal titers, and maternal treatment timing and adequacy. So this is what is important. Now, basically what CDC has done is it is divided the treatment in the infant into 4 clinical scenarios, which I have the slides, but I will not be going into the detail because that is the pediatrician's part. But as obstetricians, what we need to know is that if we are suspecting, we need to tell the pediatrician whether she was screened, she was not screened, treated, not treated, and what we are suspecting. Then, of course, they have various clinical scenarios in which they would give the treatment. So why is maternal treatment so very important? Because if we do optimal treatment during pregnancy, it will reduce the risk of congenital syphilis by 97%, almost 100%. Preterm birth by 64%, and neonatal mortality by 80%. So penicillin is the wonder drug. It is totally, you can cure the syphilis at that point of time. So 3 injections of benzathine penicillin, if we do not know the previous history, and most of the times the patients are coming to us, they would not know when they've had the infection. So we generally take it as, duration, unknown duration, and we give them 3 shots weekly of benzathine penicillin. So those 3 shots, and look at how the neonatal mortality and morbidity gets so much better. So these are the treatment scenarios in which you have proven disease in the neonate, possible congenital syphilis, less likely and unlikely. So there are various follow-ups for them. As pediatrician, we can remember the thumb rule of 4. That means mother is treated 4 weeks before delivery. The titer is adequate when you are treating if it decreases 4-fold, and neonate's titer is not 4-fold more than the mother. So this is our rule of 4, which we need to remember. And syphilis in HIV infected patients, Dr. Atul has already touched. So we just need to remember that their decline in antibodies might be slower. That is all we need to know. Now, prevention of maternal to child transmission is again where we have a role. And so we need to screen all the pregnant women. Screening should preferably be done before 16 weeks, so you have ample time to treat her, and treat all seroactive women with benzathine penicillin. Advise women that if you are positive, your partners need to be tested and treated as well. And if they are negative, please promote barrier contraception so that they do not catch a new infection or a reinfection during their pregnancy. And test all women for syphilis if they have an adverse pregnancy outcome, like I told you, a 2nd trimester abortion or a stillbirth or a syphilitic infant previously. And screen women who are VVRL syphilis positive, please screen them for other STIs, especially HIV. Make plans for treating the baby at birth. And one golden rule is no infant should ever be discharged from the hospital without confirmation of negative maternal serology. If the mother does not have a VDRL, please do a VDRL after delivery. But it has to be done. WHO has also realized the epidemic of syphilis which is happening, and they have called for action for elimination of NTCT of HIV and syphilis by 2030. And the targeted processes are that we cover at least 95% of women antenatally. Syphilis testing coverage should be at least 95%, which we are lacking. We are close to only 40%. And treatment should be of more than 95% women, which again we are lacking. We are only 70%. So these are the areas we really need to look upon. And in the end, I would like to end by saying that maternal syphilis has got adverse pregnancy outcomes. All women have to be screened for syphilis. Gestational age, stage of disease, and maternal treatment are the important factors which influence fetal infection. Of course, screen them for other STIs, and treatment is based on various clinical scenarios. So syphilis is a preventable disease. So let's do all that we can as obstetricians to have a healthy baby. Thank you.
read that wonderful presentation, I have two comments to make. I would just like to say that it is good idea to check PDRS for both the partners at the time of birth. Because sometimes the woman may be negative, the father is positive, and she may be intubated. So you are aim is not to have a baby with an inclusive. So she will have a, you are relaxing as a medical end.
Generally, that's what we are writing, both husband and wife.
Yes.
That's what we're doing.
You should make that a
Yeah. We tend to forget the husband. Agree with you totally.
If a woman gets infected, say, as a sexual encounter at 24 weeks, she will be protected.
For what? Sorry?
The book layer formed around
Okay.
it's a very good barrier for the pregnancy. So if she was a negative girl and so she had a sexual encounter
And becomes positive later.
with her husband, so that is where the understanding is that when media are both husband and wife. Whereas wife is negative, husband is positive.
So you would be more alert.
Yes. So that she may have the initial encounter, she will get infected. But if she has an encounter later on, she will not be affected. So this is why I
No,
said
that's, I think that's a very valid point that we do.
Well, thank you very much, Smita. Nice to see you back after long. It's a pleasure to have you. I think it indeed has been a wonderful session. Thank you very much. I think we give a clap to all of us, both Dr. Atul and Smita did a really just good session. Of course, thank you all of you wonderful people for each time we have to have your all the absolutely teaching program. Thank you.
Looking at the Indian diet, in 2020, there's 1,03,000 some small school and 16,000 babies have been born. So this is not the 2020. In that speaker session also when we write in sport, we read about hepatitis already. I only draw a square. This is for H and W. And the rest of it. HPLC may not take an expensive test, women like to have it. Forget about that. Or even if you know the man, it's fine.
Yeah. Choti. So don't be scared. I'm not delaying the lunch now. So thank you. Sure. And very fast. Thank you, Piotr sir. Thank you, Geeta ma'am, for this wonderful session. Now for the vote of thanks, I deem it a great honor to propose a vote of thanks today on this occasion. Let me first start with the organizing team, including Dr. Chandra, who worked really hard to make the CME a successful one. First and foremost, then Dr. Gangadhar Sahu, who is the president ISOPA, who despite his busy schedule, took out time to be with us in today's program. We are grateful to Dr. Gujral for her constant encouragement. Her able guidance has always been encouraging for all of us. Now coming to the speakers, everyone has been wonderful, giving elaborate talks. Dr. Priyamboda, Dr. Pooja Khosla, Dr. Dinesh Kaur, Dr. Kanika Chopra, Dr. Atul Gogia, Dr. Sumita Mehta. Everyone did justice to the topic, and the two important things, HIV and syphilis, which we listen to these things every day, but we are not very aware of it. So thanks a lot, speakers, for being so elaborate. And then our experts, Dr. Richa Diwan, Dr. Harsha Khullan ma'am, our panelists, Dr. Garima, Dr. Himshweta, Dr. Mamta Dagar, Dr. Tripti, Dr. Morvi, Dr. Latika Valla ma'am, Dr. Pragya Mishra, Dr. Mala, and Dr. Beodra sir and Dr. Geeta ma'am. So I'm really grateful to all of you. And not to forget our backend team, and my heartfelt thanks to all of you for making this CME a great successful. Thank you, everyone. Please join us for the lunch.